Yeah, good evening, everyone. We welcome you all to OrthoTV online in association with West Zone of the Indian Orthopedic Association. To introduce today's topic and the speaker, I hand over to Dr. Ajit Shinde, who's the president of WZ IOA.
Thank you, Neeraj. Respected dignitaries of IOA and my team members of West Zone IOA, Dr. Vikas Jain, Dr. Bandekar, Vice Presidents and Secretary Dr. Navin Thakkar, President Secretary of Maharashtra and Gujarat Orthopedic Association, Dr. Vasudevan PN, Dr. Narayan Karne, Dr. Govind Bhai Purohit, and Dr. Kamlesh Dev Murari. All the respected faculty members and my dear friends, good evening and welcome to 9th webinar of West Zone of Indian Orthopedic Association. Friends, we have been discussing office orthopedic topics which form the main bulk of our day-to-day practice. Up till now, we had a great insight in management of various conditions we come across in OPD. Today, we have another set of interesting topics and interesting panel to discuss the issue. I welcome Dr. Pradeep Choudhari, Dr. Kiran Shete, Dr. Aroop Mukharjee, Dr. Neeraj Bijlani, Dr. Ashok Ghodake, Dr. Sanjeev Bhandari, and Dr. PN Vasudevan as our guest faculty. Today, we have a variety of topics. It will be interesting to learn etiquettes of PowerPoint, presentation, and use of digital media in orthopedic. We are also going to see management of low back, colles fracture, periarticular injections, hand splint, and use of DMARD in rheumatoid arthritis. All of the faculty is experienced stalwarts from the field and need no further introduction. So without wasting further time, we will start the program. I congratulate and appreciate the effort of convener Dr. Narayan Karne and moderator Dr. Ashok Ghodake and our coordinator Dr. Ashish Phadnis and Abhijit Kale. Thanks team OrthoTV, Dr. Ashok Shyam and Dr. Neeraj Bijlani for their support. Thank you everyone for your patience really. Over to Neeraj.
Thank you, sir. With this, we'll take this in parts. The first part will be on digital. So I invite Dr. Pradeep Choudhari to kindly share his screen and start his talk on PowerPoint presentation.
Okay, good evening, everyone. We are all seeing my screen. Is okay?
Yeah.
Okay. So we'll just go for what are do's and don'ts, or in other words, what are the etiquettes of the PowerPoint presentation, or what are the slides, and that will help you avoid the pitfall of the bad slides. Why a good presentation is needed? Because it is very important in every presentation who says, what says, and how says. Who and what is you can control, but your presentation is how you say in your presentation. That is very important. What impact you are going to give in your presentation, that we're going to discuss with that. What tips to be covered? The outline, the slide structure, fonts, color, background, animations, graphs, spelling and grammar, short form and abbreviation, number, name and date, and conclusion. This is the outline of the today's talk, what we are going to discuss. Make your first or second slide on outline of your presentation. For example, the previous slide I have given the description what I am going to talk about this presentation. Why you want to do this? Because you may be unknown to the audience. Topic may be unfamiliar. Title gave little clue about the content. It's an abstract index or back cover of the book. So you should give an outline of the talk in a first or second slide. That is very important. Only place main point in the outline slide. You don't have to put the final details in your first or second slide in outline slide. Only put main points and follow the order of your outline for the rest of presentation. That is very important. Use 1 to 2 slides per minute of your presentation. Write in point form, not in complete sentence. Include 4 to 5 points per slide. Avoid wordiness. Use keywords and phrases only. These are the basic thumb rule of the PowerPoint presentation. Now see, this is a bad slide. Too much written. The audience will not going to read all this thing. So what is this good slide? Show 1 point at a time. That will help audience concentrate what you want to say. Will prevent audience from reading ahead. Will help you to keep your presentation focused. Use at least 18 point font is on the slide is minimum. Use different size font for main point and a secondary point, which I used in previous slide. Like this. This font is 24 point. The main point font is 28 point, and the title font is 36 point. So use different size font for main point and secondary point. Minimum font should be at least 18. Use a standard font like Times New Roman or Arial. Don't use like this is a very bad slide with so small font. The audience will not able to read it. Capitalize only when necessary. It is difficult to read and it amounts that you are shouting. So don't capitalize only, and capitalize only when it is necessary. Don't use a complicated form which is written here. Use a color of font that contrasts sharply with the background. Nowadays, it is black and white is considered to be with the LED screen is the best is there. Use color to reinforce the logic of your structure. Light blue title and dark blue text, there is example is there. Use color to emphasize a point, but only use color font occasionally. Using a bad color font that does not contrast with the background color is hard to read. This is a bad color font. Using color for decoration is distracting and annoying. Don't use that. Using a different color for each point is unnecessary. Using a different color for secondary point is also unnecessary. Trying to be creative, but it's also bad. Don't be so creative with color fonts. Background. Use background such as this one that are attractive but simple. Use background which are light. Use the same background consistently throughout the presentation. Now I have used some bad. Now this is a bad background that are distracting and difficult to read. This is again background with the animation coming. This is bad. This is again a bad background. Do not change background whimsically or aberrantly in your presentation. This is again always be consistent background that you use. Don't use sharp, attracting or color which are bad to the eyes. Don't use those colors. Animation is used intelligently, then it is good. Otherwise, animation is used for transition of the slide, for appearance and disappearance of the line, paragraph, or an image. It can be used. Like now, these are all bad animation. These are all distracting animation. You should not use those type of animation. These are all. I'm giving you example of bad. These are all bad animation. Do not use distracting animation. Do not use irrelevant animation. Yeah, these are all distraction. Should not be used like this. Do not go overboard animation. Like every slide, somebody is having 10 animation. These are all bad things. These are all you see bad. These are all bad animation. Animation irrelevant to the topic. This is again nothing to do with that. They are used only for decoration. Use aberrantly. No. Bad slide. Animation irrelevant to the topic. Structure, like this is again a bad animation. People are using this. This is also bad. Do not use animation for transition in slides for teaching purposes. Animations cause interruption, distraction, diversion, disruption, disturbances from the theme of the importance. Good animation is be consistent animation that you use. Use animation to make a point clear and easy to understand. Like suppose if you're an ophthalmologist, you can use animation for convergence and for divergence. Video clip in the form of animation, use it is whenever required to emphasize a point of interest. That's why you use videos, otherwise you don't require. Use graph rather than charts and word. Like somebody uses and graphs easier to comprehend and retain them in there. Trend are easier to visualize in graph form. The charts and words the better is a graph you use. Always title your graph. Like this is a graph, is a bad. Nothing is given. No title is given. You can't comprehend what the speaker wanted to tell you. This is a major surgery done in first quarter 2011. So that will give you, this is a good graph. This is a bad graph. No title is given. Now I'll just discuss. Now see, one is good, other is a bad one. Now what is good is title is missing. This is bad. Title is missing. Minor grid lines are unnecessary. Fonts are too small. Colors are illogical and shades are distracting. So this is a bad graph and that was a good graph. Title is there. No minor grid line. Fonts are readable. Colors are harmonious and no distracting shading. So these are a good and bad graph. Illustration, a picture is worth 1,000 words. It helps in understanding. So pictures should be given, but they should be, it's relevant and it should be remembering. It should not, there should not be irrelevant picture should be there. This is again a picture which giving you a wound is there and repaired. So the illustrations are, these are good. Abbreviation and short form should not be used in any presentation. Like LP is stand for so many things. What you are talking about, nobody knows. So short form should not be used without them using in full form in prior sentences. That is a must. Short form may not be known by audience of mixed faculties. Short form and abbreviations are used as empirical basis, not having any standard method. So better to avoid them as much as possible. Avoid SMS or WhatsApp language in your presentation. Use bullets for emphasizing. There are people use empirically bullets, numbers. So bullets for emphasizing different points. Numbers are used when you enumerating something like causes, branches, factors, diseases, procedures. Then you should use the number. Use simple and non-attractive bullets. Size should not be more than 70% of the font of that particular bullet. Proof your slides for spelling mistake, the use of repetitive words, grammatical error you might have made. So these are all give a bad impression on the audience if you're not, spellings are wrong or words are repeated sometimes. And if you're not having good command in the language, please have someone else check your presentation, or when you are in a short form presentation, always the red line is there. So always right click and then check what alternative spelling is there. Insert number, name and date. It helps in sorting and arranging slides. Give clue regarding progress during presentation, like name of the orator, institution, give recognition. So always put that. Date also assists to keeping records. So slides should have a number, maybe have a date, and may have some sort of a like this. When you go for a conclusion, a complex, complicated, convoluted with full of data and repetition of ideas invite loss of attention and boredom. So conclusion should not be like that. A difficult, hard to understand presentation is not a key for a winner. Presentation is for easy, simple, straightforward, and uncomplicated conversing with the audience. It should be made to convey message of an article or research work in grateful, effortless, and easy to understand form. Use an effective and strong closing. Use a conclusion slide to summarize the main point of the presentation, suggest future avenues of research. And at the end, when audience grasps some idea, they will always also remember you. So it is always like that. Conclusion should be strong. It should not be complicated one. At end of the presentation, a simple question slide. Invite audience to ask question. Provide a visual aid during question period. Avoid ending the presentation abruptly. Any suggestion to improvise the presentation? Any question like this should be asked in the question. Like this is never end your presentation with a thank you. This is a very bad thank you slide. You should end your slide. Even if you want to put a thank you, put on the last slide, which is having a summary. Because audience will be, when the question answer there, audience will be seeing this slide. So this doesn't look like nice. Thank you very much for your patient hearing. Neeraj, I'm done.
Yeah. Thank you, Pradeep, for the crisp presentation. I have one or two comments about your presentation. So it was very good that you should not use animation just because for the heck of it. That was a very good take-home message. Yeah. Second was most important is that whenever I am doing a presentation or Dr. Pradeep is doing a presentation, you will not see a thank you slide even. So we never put thank you slide. You can, of course, orally say thank you. Yeah. But the last slide, which remains, most of the 2 slides which remain maximum in your presentation, if you have given, especially in a big conference, you have been given only 5 minutes, 7 minutes, or 10 minutes, it will remain on the slide is the first slide and the last slide. They will remain for the maximum number of time, because when you are starting up, that may be just put up by the audiovisual guy. And when you are ending, you are waiting for the questions to come up. So your last slide should be there. So your last slide can be a take-home message or can be a case or a question as he put it up. And the first slide also should be something similar that people should get interested. It should not be a title slide that basically it's a title and that is why it's something like that. Something like supposing if you're speaking on, say, spondylolisthesis, or if you're speaking on an injection technique. So maybe you can put it up a case of, or an MRI picture that basically this is the slide. Now tell me what you want me to do of it. Something like that. It is very important.
Or you can put a, like, suppose you are treating any fracture, so algorithm can be there, your last slide, like what the management plan or flow chart. And then if you want to say thank you, then put thank you on that particular slide only. Otherwise, no need for last slide to give a thank you.
I want to just say one thing. Actually, this PowerPoint presentation, good tips were given by Dr. Anand Thakur long back. And I still remember, you said Times New Roman or Arial, but he said Times New Roman should not be used because it has some small things like this. You should always use Arial, or even people use Comic Sans. That can be okay, but usually don't use Times New Roman was the message which was given by him, as I remember. I am always using Arial. That's always the best thing.
The message is that you should not use complicated fonts. That is the issue. Times Roman nowadays, Dr. Bhandari, the fonts are so many nowadays. Earlier it was 10, 20. Now you are having, if you are having a Apple, then different fonts. Many fonts are there. So which is simple and attractive and readable. That is the key thing.
Two more points you said very nicely, that the font should be between, say, something like actually not 18. I usually think between 20 to 36 only. Some people use like 50, 44 or something. वो अंक पे है जैसे लगता है. You feel that
my point is that 18 is the minimum, and then you can 36, 24,
and
18.
28 for title and 24 for that thing.
Agreed.
Is really a good thing. And again, contrast. The contrast.
And if at all your slide is busy, then it should not be less than 18. If your slide is a busy one, then should not be less than 18. That is the point.
I think that some of the members of the audience are a bit visually not that strong. And
yeah, agreed.
Very small fonts, 13, 14 lines on a slide, all bad contrast. Then people just give up. They just don't give any attention at all.
Yes.
This is one more thing which should follow, definitely. These are the common mistakes. That's why I'm insisting that you have said it nicely. These are the common mistakes we see.
Thank you.
Okay. If there are no more questions, I will start my presentation.
Yeah.
Can you see my screen? Just let me know if you can see my screen.
Yes, we can see.
Yeah. So most of us take pictures, like my topic is on use of digital media and orthopedics. So most of us took pictures of MRIs, which is very common now. Patient comes to me with nowadays, sometimes one, sometimes two MRIs. Most of the patients come to me with an MRI. They have not taken an MRI. They ask me, "Ki mera MRI kyun nahi kar rahe?" So this is a very common picture which I will take from my iPhone. And this is how it looks. Though I can make a diagnosis, but there are 2-3 issues. One is that you can see the patient's name. You can see the diagnostic center's name. You can see some white background and the image is generally bluish. So what I'm going to talk about today is clinical photo editing using an iPhone. Though you can use the same features on an Android also, but because I use more of an iPhone, I'm going to talk mainly on iPhone. And the topics which I'm going to cover are the mainly MRIs or editing, the clinical picture editing, and making collages. So this is the image which I showed. Normally it comes like this in a camera. It looks very bluish and the identity is there. So what do I do to edit it? So now in iPhone, you don't need much. You just need the iPhone Photos app or the Google Photos app where you can do a lot of editing, simple editing. So this is a small video where you can see I'm showing that this is the photo which I had taken. It has come bluish and it has come from far. Now I want to edit this photo. So I just click on edit on the right hand top side of the iPhone screen. And then I get a lot of options. Then I get an option where I can straighten the photo if it has come diagonally, or I can crop it. This is how I'm cropping it. And once I am satisfied with the crop, I will just make it very small, and I will see to it that try to exclude the patient's diagnostic center's name and the patient's name out of it. If it has come diagonal, I can make it straighten. And then after that, there is an option called filters. So at the bottom, the filters will appear, and I would select mono. There are other 3 black and white filters, which is silver tone and the Noir. But I think for this image, mono works. For some X-rays, the silver tone work may better. And then I would just save it, and I will click on done. Of course, you can always change the brightness, make it a little better, so it looks better. There is brightness, saturation, brilliance. There are so many other options which you can do depending on how much time you can dedicate to it. But some basic editing is required, where you need to remove the patient's identity and make it look so that the diagnosis becomes very clear. Saw the difference, how it was blue, and now it has become so clear, black and white, like a normal, how it's supposed to be. And this is the final image, and you just save it. However, the disadvantages in the iPhone is that whenever you are trying to edit an image, always try to make a copy, because if you have edited the image, the original goes away. So always try to make a copy of it and then try to save it. This is how it looks. Brilliant. The patient's name is gone. Only the date is remaining. That is what we need. And the diagnosis, we can see that it's a classical medial meniscal tear. Now we talk about the patient's identity. In 2020, 2021, it was very easy to actually hide the patient identity, because most of them used to come in masks. So though this patient is in mask, you can still make out that who he is. So how do we hide the identity of the patient? Using the simple editor on the iPhone. So again, on the top right, in the Photos app, there is an edit option. I click on that. And after I click on that, I get these options in the bottom, where I can actually do some drawings. But for this, you will need an external app most of the times. But if you're using a Galaxy Note where there is a S Pen, or the Samsung phone where you still have a good gallery app, they have these features inbuilt. So I would like to edit these images a little bit. And after that, once I've done with a little bit of editing and making it straight and making it brighter, I would want it to go in an external app where I would want to draw on it. So I would use this external app. These are the external options available for me, and called something called as markup. So when I click on markup here, I get these options of drawing. As you can see, I get these multiple pens, and I'll just select one of the pens, and with a black color, preferably, or a red color, I would want to hide whatever is identifying the patient. So here there are 2 things which identify the patient. One is the belt of the patient, and one is the face of the patient. So I'll just draw with a fat pen, and it will get hidden. And same thing I will draw on the belt also, and it will get hidden. If you want, you can use an external app where you can insert a shape, or the Galaxy Note phones allow you to directly insert a shape in it. So this is how the photo comes, and the identity is hidden. So mainly for clinical picture, you need to hide the identity. Then I come to something called as making a photo collage. Sometimes we don't need to send separate photographs. It becomes too much to send on WhatsApp. So it is always easy to make a photo collage of 1 or 2 photos and send it. So it's for a better explanation. For that, I use an app called PhotoGrid. It is a third-party app available on Android and iPhone both. This is how it looks. So I open PhotoGrid, and I select this first option called Grid. And after I've selected, it allows me to tell me to select photos. So I can select 1 or 2 photos here. And I have to select a grid. So maybe I will select this one or this one. So 2 photos side by side. I can, of course, add a photo from here. Then I click on this photo, and then I select 1 photograph of the MRI, and select another photograph of the same patient of the MRI. And that is, I can just put an arrow on it if I want by using the markup. And I can adjust these photos so that it looks like a very classical. I can, of course, write a text on it. I can even write do drawings on it. And I can even put my name on it so that if anybody wants to copy, my name will go with it. Though it is a paid app, but it allows you to do many things for free. So don't pay for it. Use mainly with free, but you get that photo grid thing on the bottom. That's the only disadvantage of the free app. But that works for most of the time. Then I come to the next feature, which is called the combined photo and video collage. This is very useful if you're using a lot of Instagram nowadays. You can make an Instagram reel, you can make an Instagram story out of your simple photographs by using this app. So again, I select a grid here. And this time I will select a grid of 4 things, which will be 1, 2, 3, 4. So I will select, there are so many photographs. Last year, I had a chance of visiting Sancheti Hospital where they have installed the O-arm, and Dr. Shailesh Hadgaonkar demonstrated the surgery in O-arm using O-arm. So I'll select these 4 photographs and a video. I will keep on selecting. So I select up to 4 and it automatically gives me options. So I'll select, these are not the good options. So I'll select a plain option, which was the first one. See, there are always designs, but I will select this first one because I want to make it look, we are using it for professional purposes. And then each and photo and video, I can use it and mark it up. I can remove the sound if I don't want the sound. I can keep the sound of one video. So this is the O-arm navigation system. And then I have adjusted the video so that it appears that we are looking at this as Dr. Shailesh is explaining it to me. And these are the photos. One is with Parag Sancheti and one is with Dr. Shailesh, where behind is the O-arm. So this appears very good when you are sending it as a video. You can put this up on your Instagram stories or your reels and it appears really good. And this is how you can make a combined photo and video collage. And you can remove the sound. You can put your own music, put your own sound. That is up to you. So with the simple free app Photo Grid, you can just export this as a video. And once the export is finished, this is how your video looks. And you can see that how this looks very classy, that though I'm looking at the screen and the screen is on the left side. So you can make some nice videos of these small things for your own self. And also you can make a combined video. So from my side, this is it. Thank you very much. Over to you, Dr. Ashok Ghodake. And if there are any questions from the house, I'm ready to take them.
Oh, excellent presentation, Neeraj. I would like to ask you this today's presentation. You prepared it before, or you are just showing it on the screen?
No, it is not live. It has been prepared long back. In fact, it was prepared last year because that is the time when I visited Sancheti Hospital. So it is. But what I do is that I use my iPhone. Even in Android, it is possible. I use the screen recording feature, and with the screen recording feature, I record the whole editing part, and I then put it on my Keynote in my Mac. I can also put it in the PowerPoint, the same video. So it gives me an end result is a video of the whole procedure which I did, like the editing of the photo grid and everything. And then I can just save it as a video and then I put it in my presentation. So this is a proper presentation. I have not shown my phone. I have not connected my phone.
So it was looking as if you are editing it right now during your presentation.
That is how it's going to. That is the whole. That was my whole purpose, because somebody who's trying to do it should be able to follow the step-by-step instructions. Thank you very much, Ashok. So if you're saying like this, my purpose is solved.
Yeah.
Yeah.
If there are no other questions, I would I'd invite Dr. Sanjeev Bhandari. He will talk on periarticular injections for routine orthopedic problems. Bhandari sir, please.
Yeah. One sec.
Dr. Pradeep has a question. Pradeep, you are muted.
Neeraj, I might leave in between because of some other commitment if Dr. Ashok will allow me.
Yeah, no problem.
Okay. Yes. Thank you, Dr. Pradeep.
Thank you.
So, thank you, Ashok and Neeraj and all other faculty members. My topic is about the periarticular injection techniques, which I am using extensively for last nearly 35-40 years. And one second, I'll just put this view thing. Yeah, so over the last 35-40 years, I have really, I know I can say confidently that more than 90% of common orthopedic problems can be effectively managed non-surgically. But when I was a PG teacher for last 15, 20 years, I have noticed that students are extensively interested in only learning the surgeries, the surgical skills and the techniques. But when you want to teach them some conservative means, they are not that enthusiastic. And so I really thank Dr. Narayan Karne and their team who have taken keen interest in this office orthopedics thing, which is the art and science of non-surgical management of these common day-to-day orthopedic problems, which can help the patients a lot. And in this non-surgical management, injections play an important and vital role. These injections can be diagnostic, as you all know, subacromial injections or diagnostic root blocks, etc., where we just inject the local anesthetic to ascertain the source of pain. But majority of the times, I use these injections as therapeutic injections, where there's a mix of local anesthetic with a corticosteroid preparation, either triamcinolone acetonide or methylprednisolone acetate. Actually, to begin with, we were using the hydrocortisone acetate, which was marketed by Russell. It used to come in 2 ml ampules, but it faded away from the market. And so now I have shifted mainly to methylprednisolone, which is my preference, and otherwise sometimes the Kenacort or the triamcinolone. I'll not go into the details of how a corticosteroid helps in the inflammatory conditions. The only thing is that it reduces the inflammation and vascular congestion. And as it is, these areas are relatively avascular, no systemic absorption and side effects are seen. Now, I'll be coming to injection techniques for common orthopedic problems. And as I said, I have used it in more than 40 to 50,000 patients, and I'm very happy about these. Maximum number of injections I have done for knee problems, then 20 to 25% for shoulder, and remaining 15 to 20 for other conditions like fibromyalgia, plantar fasciitis, tennis elbow, chronic sprains and facet injections, etc., etc. That the broad categories of these therapeutic injections are mainly periarticular injections, about which I'm going to talk today. Then very rarely intraarticular injections like the first carpometacarpal joint, the acromioclavicular joint, the temporomandibular joint, etc. And last is the local connective tissue injections like fibromyositis, plantar fasciitis, tennis elbow, etc. So I will be talking mainly on the periarticular injections, which forms the bulk of my injection techniques. Now, my usual regimen is like the course of 1 to 3 injections, depending on the location and severity. The frequency is usually I like to inject at weekly interval, 2 or 3 injections for major joints like shoulder or knee joint, and only 1 injection for many other smaller joints. The maximum interval can be sometimes up to 3 weeks if there's an outstation patients and they cannot come really weekly. Of course, in addition to these injection techniques, supplementary treatment in the form of NSAIDs and physiotherapy, plus mobilization as well as training exercises are advised. And this is my hospital file on which mainly the 3 degenerative conditions which we treat with, like osteoarthritis of the knee, the lumbar spondylosis and cervical spondylosis. For that, what you have to take care of and how to do the exercises is illustrated so that the patient can follow it nicely. Of course, the possible complications, first, which I have noticed in the beginning is the stretch pains. We are giving these injections in fibrous tissues. And so to begin with, for about 12 to 24 hours, patients can get stretch pains. And for that, I usually mix this steroid with a local anesthetic and also give an injectable analgesic along with it, like a diclofenac injection or a tramadol, that is tramadol injection, and also a short anesthetic course till they have some pain. Second important thing is infection, especially in diabetics. And as I have noticed in frozen shoulder or the adhesive capsulitis, many patients don't know that they are diabetic. But once you do their blood sugar levels, you find that they are diabetics. And in these situations, if the blood sugar level is high, you wait for the control of diabetes. And if it is, say, somewhat higher up, then you can use an IV antibiotic and give the injection. Also, for all injections, strict aseptic precautions are essential, and always it is better to give in a minor operation theater or a sterile procedure room and not in your OPD setup itself. Now, coming to the periarticular injections, most common indication for me is around the knee joint, and in the periarticular injections around the knee joint, I have used these injections mainly for osteoarthritis of the knee, grade 1 to 3. Also, some chronic sprains, like usually grade 1 or maximum grade 2 sprains, like medial collateral ligament chronic sprains or posterior-medial capsuloligamentus sprains. These injections work very nicely. Of course, sometimes even for osteoarthritis grade 4 or 5, when the patient is either unwilling or not affording for a total joint replacement, I use these periarticular injections and they get good relief, but it may not be long lasting. Now, this is a case of grade 2 medial compartmental patellofemoral osteoarthritis. You can see that there are small marginal osteophytes which are coming from the medial femoral as well as medial tibial condyles. And in the lateral X-ray, you can see that there is a small osteophyte which is coming from the superior pole of patella. Now, these osteophytes usually in certain situations, after certain strenuous activity or some strenuous function at their home, etc., the patients can get exacerbations of this osteoarthritis. And there is periarticular inflammation at these two specific spots, which I have noticed over the years. And these are the main tender spots which most of the times this will be present in the osteoarthritis knee patients. One is along the medial joint line near the junction of the superior lower inferior pole of patella and the middle femoral condyle. And second is at the superior lateral pole of patella. In osteoarthritis of knee, there is always tenderness along the medial joint line at the junction of the medial pole of patella and the medial joint line. And the patient is having pain here, you can see that. And the second tender spot is at the superior lateral corner of patellofemoral joint. See the patient wincing when I am pressing there. These are the two common spots where I will be injecting. So, many people like to give intra-articular injections, but I have never given intra-articular injections in the knee joint, and I will always give periarticular injection. I will go down there at the first spot, hit the bone about 1 to 2 millimeter above the joint line, and then infiltrate about 1 ml of methylprednisolone along with 1.5 ml of xylocaine, and the remaining 1 ml plus 1.5 ml of xylocaine will be injected at the superior lateral pole area, which I showed in the beginning. Here also, I'll hit, and in the flex position, the suprapatellar pouch and is obliterated, and so there is no chance of going intra-articular. Another patient having the same thing about grade 3 osteoarthritis. These are the two spots which are being injected. Many patients have bilateral osteoarthritis, and you can inject both the knees at the same sitting. This is the right knee which is being injected, and this is the left knee which is being injected. All these patients, after first injection, they will get about somewhere between 30% to 60% pain relief. And after second injection, usually more than 75% pain relief is there. And in grade 1 to 3 osteoarthritis, if they follow the instructions properly after the injections, these pain relief lasts even for years, which is my experience. If they really go on doing the exercises properly, and if they really don't squat too much or don't climb the stairs too much, then they can have good relief for months together or years together. In some osteoarthritis cases, I have, especially when there is marked genu varum, I have found that there is a tenderness at the distal attachment of the superficial part of the medial collateral ligament, and I usually inject at that spot. As you can see here, here I am injecting at the. I have marked it here, and I am injecting at that spot on the. And then second spot is at the superior lateral corner. Another case where there is genu varum, and I am injecting at the distal medial collateral ligament, and another at the medial joint line. This lady did not have much patellofemoral osteoarthritis or pain, so at these two spots it was injected. As I said, very good relief with 2 to 3 injections is there, and then other supplementary treatment if the patient does it nicely with physiotherapy, lifestyle changes, and weight reduction, cordyceps and hamstring exercises, and And in some of the cases, last 4-5 years, I'm giving intra-articular hyaluronic acid injections in selected grade 2 to 3 osteoarthritis cases, along with the second or third periarticular injection. And then I have seen that nearly 2 to 3 years, the patient is pain-free. So these intra-articular hyaluronic acid injections as a supplement, not with the first injection, because it has been noted, and I have attended certain conferences, they have said that if you give only the intra-articular hyaluronic injection, after the first injection, the patient gets for about 2 to 3 days or 5 days, the patient can get increase in pain. So I usually give it with the second or third periarticular injection, and usually the patients don't experience any increase in pain of their osteoarthritis. Other indications for periarticular injections around the knee, as I said, chronic painful grade 1 or 2 sprains with no obvious instability. This is very important. No obvious instability. Usually you will get patients having medial collateral ligament sprain with localized tenderness at the proximal attachment of the MCL at adductor tubercle, and you can inject it there. And second is chronic posterior medial corner capsuloligamentus sprains, and the patient points directly at that spot, and only one injection usually suffices. With that, the patient gets very good relief. Who is suffering for nearly 6 months or 1 year, he can get very good relief. So this is a case where there was chronic painful grade 1 medial collateral ligament sprain. Varus valgus XA, you can see that there is not much opening up at all. This was the spot about 2 to 3 centimeters proximal to the medial collateral end at the adductor tubercle. And here I have injected 1 ml of methylprednisolone along with 1 to 2 ml of xylocaine, and usually the patient gets very good relief. And it is probably 1 injection will suffice and will give permanent relief. Similarly, this is chronic posterior medial corner sprain, grade 1, not much instability, and you can inject it there, and the patient will get very good relief. Many people come to me after consulting 2 or 3 or many orthopedic surgeons, and they have advised them exercises and all those drugs. But with this 1 injection, they will get very good relief. Another patient with similar posterior medial corner relief, and he is being injected. Now, second most common site after knee is the shoulder. Most common thing which we encounter in the OPD is the periarthritis shoulder, and the next stage is the adhesive capsulosis, which you commonly refer to as frozen shoulder. Then subacromial bursitis or rotator cuff tendinitis, acromioclavicular joint arthritis, and bicipital tendinitis. Now, coming to the periarthritis shoulder or adhesive capsulosis frozen shoulder, the painful and restricted movements are 3. That is all of us know: abduction, external rotation, and taking hand behind the back. Now, the most painful and tender spot in all these conditions I have always found is at the anterior capsuloligamentous complex. This is the spot where the maximum tenderness is there. Ask the patient to take hand behind the back as much as he can or she can, because in frozen shoulder, this movement is restricted and severely painful in many conditions. And inject at the most prominent point anteriorly, which is always most tender. So this is the injection which I am doing at the anterior capsuloligamentous complex. I have found very common association of as we call the triad of frozen shoulder with cervical spondylosis, with fibromyalgia and diabetes mellitus. So fibromyalgia is isolated along with the cervical spondylosis, and it is usually associated with frozen shoulder. So this is the spot. I ask the patient to take the hand on the beyond the opposite knee, so that the shoulder blade of the scapula is stretched. The medial border of the scapula is palpated, and then if you go down along the lower border of trapezius medial to it, you can find about 1 inch below that a very painful tender spot, and that is the usual spot of fibromyalgia where you can inject. So this is a patient with severely painful right frozen shoulder. The abduction was hardly 40 degrees. And along with that, she had cervical spondylosis with fibromyalgia and diabetes mellitus. And see, after 7 days, abduction was hardly 40 degrees with before first injection. In these conditions of frozen shoulder, I used to do a manipulation under general anesthesia about 10-15 years back. But over the last 10-15 years back, hardly 1 or 2 out of 100 patients require manipulation. Otherwise, all of these patients are usually get full range of movement and pain relief with the three periarticular injections given at weekly interval and associated with physiotherapy and mobilization exercises. And after 2 weeks, you can see the patient is smiling with full range of movement. Of course, the abduction may take about 1 to 1.5 months to come, but the pain will be relieved within 8 to 15 days. See, this is second severely painful left frozen shoulder. She was diabetic and she was suffering for nearly 4 months. She was not allowing me to touch her hand also. It was so severely painful. And after 10 days, you can see the smiling patient with nearly near full good range of movement. Sometimes there is adhesive capsulitis with rotator tendinitis or even tear. Here I will inject entirely as well as 1 ml I will inject in the subacromial space. This was the patient. This is his MRI report, which says that there is full thickness tear of the rotator cuff involving the supraspinatus and anterior aspect of the infraspinatus tendon. He was having severe pain and not able to actively as well as passively abduct the arm. 2 days after the second periarticular injection, he was coming daily for physiotherapy and he had active full range of movement and also abduction as well as other range movements were totally improved. This is another patient with partial supraspinatus tear. He came from a place about 150 kilometers away. And after 8 days before second periarticular injection, he had nearly 60 to 70% relief. And at the end of 3 injections, he was totally normal. Now, this is an old lady. She had full thickness tear left side. Her MRI gives this report that there is a full thickness tear with actually there is a retraction of the proximal tendon. And there was no active abduction and even passive abduction was painful. I told her that actually you have to undergo this rotator cuff repair, but that lady was not ready. And so I injected her anteriorly as well as the subacromial space. And after 3 weeks, you can even see that her pain has gone. Mainly she was very happy because her pain had gone. Though there is some drop of the hand, but she could now actively lift it up and the pain had gone. Other shoulder problem which you commonly encountered is subacromial bursitis in young patients, especially overhead sports like basketball, volleyball, etc., or badminton. These patients can develop subacromial bursitis and severe pain. And here, this is the spot where you can inject. Even here, I ask the patient to take the hand behind so that the subacromial space becomes more prominent. And then I will inject 3 ml of xylocaine with 2 ml of methylprednisolone, and usually 1 or 2 injections, the patient gets full relief. Other sites for periarticular injections are chronic wrist sprains. Many times patients come with chronic ulnar collateral ligament sprains. They have typical tenderness there, and the supination pronation is at terminally severely painful. And another is the dorsal wrist sprains. So this is the chronic wrist sprain due to ulnar collateral ligament sprain. And this is another case with a dorsal sprain where I am injecting in the dorsal ligament. In malunited distal end radius fractures, many patients come to you, especially from the rural area, where they have distal end radius fracture, either untreated or improperly treated, and they come with malunited fractures. And if you will see, there is no tenderness on the distal end radius, but the tenderness is because of the DRUJ sprain, and also sometimes with ulnar collateral ligament sprain. And if you will inject at both these spots, 0.5 ml here and 0.5 ml there, you can get very good relief. Similarly, chronic lateral ankle sprain. Tenderness is at the anterior or the distal attachment of the anterior talofibular ligament. And if you will inject there, the patients, along with ankle support for about 1 to 1.5 months, they will have very good relief. In addition, there are many other common orthopedic problems which don't come under periarticular things as such. As I said, fibromyalgia, tennis elbow, golfer's elbow, plantar fasciitis, chronic coccydynia, trigger finger, etc. And in spine, facetal joint arthritis with facetal pains, where you give facetal injections. These all things are amenable to these local injection techniques. Now, is the relief temporary? I will say both yes and no. In certain degenerative conditions like knee osteoarthritis or say facetal arthritis, if you will inject, they will get relief, but they have to follow the lifestyle changes and exercises. Otherwise, the pain can recur. While in certain conditions like plantar fasciitis or even frozen shoulder, once the patient is relieved, I have never seen them recurring in the same shoulder. They may have pain in the opposite shoulder, but not in the same shoulder again. They should be, of course, avoided in insertional tendinitis, like at the insertion of tendo-Achilles, because there are chances of tendo-Achilles rupture. And nowadays, I am finding good relief with PRP injections at this size. Also, decurvant stenosynovitis, because it may give temporary relief, but you will have to the patient will have to undergo surgery for getting permanent relief. And of course, in uncontrolled diabetics, where the first do the proper diabetic control before giving injection, use strict asepsis, and even inject one IV antibiotic shot so that they will not develop infection there. So friends, injections is a win-win situation both for the patient as well as the treating surgeon. For me, it has been most rewarding because there are innumerable, as I said, 40 to 50,000 patients I have treated. So innumerable happy patients. This is the most important thing for me. One satisfied patient always brings many more. Always the patient says, "Amcha gawamade, in our village, there are so many people who are suffering from knee pains. We'll bring them," and they really bring so many patients to you. I have got lots and lots of patients from faraway places. Even one patient was brought from Jodhpur, about 1,500, 2,000 kilometers away. And many other patients who come to me from about 400, 500 kilometers away for these injections, because their relatives and friends tell me them that you go to him and you will get good relief. This is earning without stress, and there's no slack season. You can continue these injections till a much later age when you can stop your operating thing, but you can still continue with your injection techniques for a much later age. And of course, I have taught these techniques to many students of mine. And nowadays, I'm very happy that I'm getting a chance to teach this to many others through these webinars and conferences by the initiative taken by Dr. Karne and others in Office Orthopedics thing. Thank you very much.
Thank you, Dr. Bhandari. So this is a very good tool. I also give a lot of injections. However, there are two things which I do. There are two things which I do, especially for the trigger finger. I actually do a percutaneous release with the 18 number needle after giving local anesthesia and before giving steroid. What is your take on it?
Yeah, I actually, for triggering, actually when the triggering is there, first stage is flexor tenosynovitis, where with injections you will get good relief. But as you said, in this trigger finger, where the actual trigger is occurring, I will put a bigger needle, do some trigger after, first give some local anesthetic, do some needling, and then inject. And usually even trigger fingers don't need surgery. I have not really operated on trigger fingers or trigger thumbs for quite a long time. And that usually, even if frozen shoulder, what I was saying, I was really doing manipulation under anesthesia so many times. But the patients themselves taught me this because patients were coming from faraway places. They were not ready for anesthesia, or they were not fit because of diabetes. So I gave them the first injection and called them for manipulation under anesthesia for the second injection. And by that time, they used to come and say, "We have more than 50% relief. Why you want to do this manipulation under anesthesia at all? Just inject us." And for thereafter, I have started realizing that even without Muga, what we call, we can get good relief only with properly given injections at weekly intervals and a lot of mobilization exercises at home. And if they have locally, I call them for shortwave diathermy and ultrasonic therapy or interfacial therapy under my physiotherapist guidance.
Right. Yes, Doctor.
Yeah, so
I am Doctor. Oh, continue. Yes.
Please, Aroop sir, please.
I am Dr. Mukharjee, and thank you for your illumination and very good speak. But only thing, there is a confusion in the listener's mind that what is the amount of dipomedrol and what is the concentration of dipomedrol in every site. So first thing that I just wanted to know that there are certain tender points, like in decurvance, when you inject, you don't inject that much amount of fluid. In knee, you amount, that is the maximum amount you can push in the knee. But the message is that you should be ready to throw away the remaining part of the dipomedrol
When the site of inflammation is small or minuscule, that is the time when you would need only one drop. Your take in it, please.
Yeah. Yeah. See, so what I will tell you, I have even used for many finger splints, PIP or DI splint. There only one drop is sufficient.
One drop is sufficient.
For the smaller joints, wrist, etc., half ml. I said half ml of depomedrol or 20 milligram of depomedrol. For knee joint, I am not giving intraarticular at all. I am giving periarticular. At each spot, I am giving 1 ml of that is 40 milligram of depomedrol. For shoulder, I am giving 1 ml of that is 80 milligram, 40 milligram of methylprednisolone. For fibromyalgia, plantar fasciitis, I am giving 1 ml of. I always mix it with local anesthetic so that patients don't get stretch pains. And I also give along with an injectable analgesic so they don't get pain. So it depends on the size of the joint. In a smaller joint, half ml or even 1 drop may be sufficient. Half ml may be sufficient. 1 ml usually for many other spots. And total 2 ml, I will sometimes give for the facetal injection or something, or sometimes say a very severely painful shoulder, I may give 2 ml to begin with for the first injection. But usually 40 milligram of 1 ml at one spot is sufficient. And for smaller joints, even less than that, 20 milligram or even 10 milligram may be sufficient.
That is clear. Thank you. Thank you.
Many times after giving these steroid injections, patients do come back with white patches around the injection site.
Yes.
What do you do for that?
Basically, this happens only in superficial locations if you are giving. In knee joint or in shoulder joints, I have never observed it. As I said, the ulnar collateral ligament sprain or sometimes this spot, sometimes you can get that. And so actually, if you dilute them properly with the xylocaine, usually this thing I have not, previously I was giving it just the only local steroid. But nowadays I dilute it with the xylocaine, and usually this problem I have not encountered much. Maybe 1 in 1,000 or something like that.
Have you ever come across anaphylactic reaction because of use of xylocaine?
Fortunately not. 1 in 5 lakh, probably still not.
Bhandari, whenever you are giving steroid injection, you are using xylocaine also, no?
Yeah.
So that amount is also vary as per the joint.
Yeah, so for a knee joint, I will usually take 3 ml of xylocaine and 2 ml of methylprednisolone. And then I don't give them separately. I mix them together and give half of it at one spot, and remaining half at the other spot.
What about the finger joints?
Finger joint, hardly, as I said, 1 drop of xylocaine and 1 drop of thing is sufficient. But they get very good relief. These people who had some ball injury or something, they come with 6 months, 1 year or 2 years having pain using that finger, and you just inject, either it is at the proximal attachment or the distal attachment, either on the ulnar side or the radial side. Only one spot is painful. You inject 1 drop along with 1 drop of xylocaine there, and they are really getting very, very good relief, which they don't have for the last 1 or 2 years. That is my experience.
Thank you, Bhandari. Yeah, Kiran.
Yeah.
Kiran, तुमचा mic बंद है.
So just small comment on the discussion that we are having about the steroid injections. So especially the chronic spots that Dr. Bhandari was talking about, where there is osteoarthritis and ligament, attachments, especially in the knee joint, or any other places where there has been a ligament injury or laxity of the ligament, and that is causing the pain. Rather than steroid, I will prefer to do something called as prolotherapy, which is basically you can use different agents for that, like even platelet-rich plasma, or you can use a dextrose solution, which is dilute 25%. You can dilute and then use it. You might have to do it 2-3 times, but that actually helps a lot, especially those who have these ligament attachments where there is an injury or ligaments are causing the pain. Steroids do have specific role, especially I think where there is a high level of inflammation, such as tennis elbow or plantar fasciitis, where it works wonderfully. But if it is a osteoarthritis of the knee, I'll prefer to do injection with prolotherapy agents, especially at the tender spot.
What I want to say is that I agree with this PRP, etc., which I am also doing, as I said, for TA, insertional tendency, etc. But Dr. Ajit Shinde was my lecturer at that time, and Dr. Iyer was my teacher. So these people have taught us these techniques, and I have modified them over the years. And I am getting very good. I have not found any complication of giving 1 ml of or half ml of steroid at these ligament spots. I was a bit worried in the beginning. But those patients come many times to me after 10 years, 15 years, 20 years, and I have not found anything. I have used in close relatives and many friends and everything. So now I am confident that even if I inject steroid, there is no side effect as such, long-term side effect as such. And so if it is giving them good relief, I am continuing with that. Maybe we are old timers, you are a bit fresher ones, but our experience tells us this. And so many times you go with your own experience.
Right, sir. I don't have that experience probably, and whatever I have read about it and the research papers which talk about is at the ligament attachments, go for Prolo agents. So
I'll just see and do that sometimes. Yeah.
So thank you, Dr. Bhandari, for eye-opener presentation. So this will definitely help us in our practice.
Actually, Ashok, one last comment. I actually want to say that many others should take up this thing. And as I said, more than 95%, every time joint osteoarthritis go for total joint, it is not essential. Many patients can, and many people are not willing, many people are not affording. Just don't give them NSAIDs, give them these injections, and they will be really help a lot. And I want to spread this to many other people, many students and many people, so that it is done at all places and many patients are benefited. This is the main thing.
Definitely. Thank you, Sanjeev. So our next talk is on chronic low back pain with normal imaging. Dr. Kiran Shete from Pune, my good friend. I request him to please carry on his presentation.
Thank you, Dr. Ashok and the panelists. Today, I'm going to talk on a very specific subset of back pain patients, which is chronic back pain, not acute, and those whose imaging studies have come absolutely normal. There is no, pathological finding that you can see. In fact, quite a lot of patients which come to us in the initial phases of their back pains fall in this category, and there are few who come, after repeated visits to the doctors. So let's dive into the topic. Just a minute. Let me minimize this. Yeah. So today I'm going to talk about what is chronic LBP that we are talking about, the approach to such patients, identifying the causation and etiology, treatment about it, and a little bit about what research says. So low back pain, is it a symptom or a disease? And I always, tell this to wherever I talk about low back pain is, don't convert it into a disease. It's a simple symptom. It's just a symptom where the patient is in agony and has pain, and we need to treat his pain. Now, the disease or issue in his body can be a number of things, and we need to identify the disease and then treat that disease so that the symptom of low back pain will go away. Many times the low back pain itself is considered as a diagnosis, which I don't think is a good idea, especially because it has also become one of the escape route for the patients for so many other things in their life. Though it is harmless in many, that as we know 80% of people will suffer, and that statistics is well known. It has been there and it will remain there, but it is life-changing in few. I'm sure you must have seen a lot of patients in your OPD where they have a number of reports and X-rays and MRIs and everything with them, hundreds of doctors' visits, kilos of painkillers, liters of ointment, and still they are in pain. And their life has changed. They have changed their jobs, their partners have left, and from well earning to low earning to not enjoying their life at all. So this chronic low back pain is very important to be treated from its root, or identifying the causation and then going to the root of it. Many times there is no specific identifiable pathology, and we'll go forward and see how we can treat such patients as well. Patients usually come as acute pain, and they can be treated very easily. The protocols are well set for that. But which acute pains might get into chronic pain, nobody knows. right? So we really want, first time when the patient comes to us in acute pain, can we do something where these patients gets treated and he doesn't get into a chronic low back pain? Of course, chronic low back pains can start insidiously and go slowly increase pain. But many a time there is always an episode or acute pain which comes, and then there is a chronicity. So any pain which is more than 3 or more months is called as chronic low back pain, and that's what we are going to treat here. There is quite a bit number of differential diagnoses that you can see on chronic low back pain. But today we are going to talk about very specific patients where there is a normal X-ray, that is the imaging studies, normal MRI and normal CT scan. This is what the 3 imaging studies that I am going to talk about, where all these are normal, but still patient has a chronic pain. Chronic is more than 3 months, and he is trying to get a solution. That is what the subset that we are trying to talk here. So the approach is very simple as we approach to any chronic pain patients, especially starts with the detailed history. And as we know that especially in chronic conditions, history is paramount importance, especially how the pain started. And then going into the details of not only into the personal history, including smoking, alcohol, his job, the kind of work that he is doing, sleeping habits, and then of course the relationships that the patient has, any traumatic event that he has gone through, the treatments that he has done, the multiple doctors with, everything in history is very crucial, especially when the patient is with a chronic low back pain. Then I am not saying only examination, but skillful examination. Many times in our busy OPDs, when the chronic low back pain patients come to us, especially, when there is a medical college and, a lot of patients has to be seen, most of the times, the prescription is given and then the patient is asked to come again next time, or sometime, go and get an X-ray or get an MRI. And that is like, going to give us the perfect guideline and perfect identification of the reason, and then we treat it. But believe me, in chronic patients, when we do skillful examination, we will be able to get to most of the reasons why there is a pain. So history itself will give more than 50% of diagnosis, and then the 30-40% will come from the skillful examination. In that, you will have to do all types of tests, including, of course, the basic examination, which is inspection, palpation, and movements. But along with that, sensory neurological examination, the joints nearby, and very important to actually see the low back area, which is very important, because there are some pathologies which you can identify just looking at the low back area, taking out the shirt of the patient, or in case of female patient, you need to be careful, but make sure that you look at the low back area when you are going to treat that patient for chronic low back pain. After examination, if there is a need, of course, you might have to go for selected imaging. Either you choose a X-ray, MRI, or CT scan based on your clinical suspicion, and then you can evaluate it. Of course, after that, if required, laboratory tests which might be required. If everything comes normal, let's say there is a imaging which comes normal, the lab tests come normal, and then the real exploration starts. What is it that is causing the pain to the patient? And you have treated them basically with a lot of things, but still there is no relief, and patient is coming repeatedly. And this search for the uncommon is very important. That's what we'll go in further slides and see. And I'll talk about the treatment and the regular follow-ups. So the first thing is, when, let's say, you have initially, after your examination, history and everything, advise that you think clinically that the patient needs MRI scan, and you directly send patient of MRI scan. You have not done an X-ray, though I always prefer to get an X-ray done. So let's say MRI comes absolutely normal, there is no dust, there is no degeneration, there is no soft tissue injuries or any compression of the nerve roots or stenosis. Now, you reevaluate the patient, revisit the clinical examination, maybe the history also. If you clinically find that no, patient had some structural pathology, patient has some anatomical abnormality which needs to be seen either of the imaging, then you might have to go for another form of imaging, which can be either CT scan or X-ray. And there are many conditions which are seen on CT and X-ray and not seen on MRI. I think we can have another lecture for that. Or if you feel that the MRI quality is not good, or you think the sequence which was done was not proper, you want T2 images to be repeated, or want some kind of a different angles to be done, repeat the MRI. You might have to go send patient to the second set, but your clinical suspicion is very important. If you are clinically very sound that patient has a problem, and there has to be some structural abnormality, go for repeat MRI. Absolutely no problem. Either you can repeat the MRI of the same area, or you can consider again after clinical evaluation if the MRI is to be done, for example, for lumbosacral plexus, and there might be a plexopathy, or you want to do a MRI of the patient is getting radiating pain of sciatic nerve in the buttock, and you might just find a sciatic neuroma or some kind of a tumor in the sciatic nerve. And believe me, I have diagnosed patients of that conditions as well. So it's important that your clinical and suspicion is very important. So not that every MRI will be exactly the way you projected it to be. There might be surprises, but if you are very convinced about your clinical examination, go for another imaging or a repeat MRI for the same patient. If the patient has got MRI from somewhere else, you might have to repeat it. So, as I said, if you are not very sure, then of course you can go to the next stage, but very sure clinically, then go for repeat. There is also a MRI where there is axial loading which can be done. So axial loading MRI might reveal conditions which are not seen on a normal MRI. So as we know, the patients usually are sitting, moving around, traveling, and their pain increases while doing those activities. MRI is done while lying down, supine, comfortably in the AC environment, most of the time listening to the music. So probably axial loading MRI, which might be helpful to find out a condition where there is, a bulging disc might be seen, or there might be some disruption in the tissues. So you can consider that axial loading if you are clinically very sure. Supportive other imagings like obliques and stress X-rays, flexion extension X-rays, everything can be done, especially because you suspect there is something else going on there. Now, let's say that CT scan and shows you something, and then you do the diagnosis, and of course the treatment can go on. But even after doing CT, MRI, X-ray, and repeat MRI or other imaging like contrast and everything, even doing a bone scan to find out if there is any hidden tumors which can be identified, there is nothing, and then your exploration starts. And that is also another very important aspect of treating these chronic LBP patients. Now, there might be, a chance that before going exploration, we can just consider this as chronic low back pain, name it at, send it to physiotherapy, give him painkillers, give him everything, and then go for the exploration. Or you can directly go for exploration depending on at what time the patient has come to you. If patient has already done physiotherapy, all other medications and everything, then you need to identify other reasons for it. So for the simplicity purpose, I have divided, further evaluation based on these headings, which I'll go into details one by one. So first is biochemical, where you need to, or systemic illness that you can say. You need to identify basically blood test or lab test, which you have to order. So initial phases of seronegative spondyloarthropathy, ankylosing spondylitis, or the patient might be having, psoriatic arthropathy, they can present where there is only a back pain and there is no identifiable structural abnormality which can be seen on imaging. Other inflammatory conditions such as increased uric acid or rheumatoid arthritis and other rheumatoid conditions also can give rise to back pain where there is no structural abnormality, especially in young patients. We need to be careful while ordering the blood test for them. Vitamins are again contributory reasons for the back pain, but they are at times, I have patients where you just correct the vitamin D or B12 deficiencies and the patient's pain just goes away, even if they don't do exercise. And that's another way of looking at, when you want to order the blood test, go for especially B12 and vitamin D. Other micronutrients, if you feel that patient is has some genetic history or, history of congenital problems where there are deficiencies of some micronutrients, again, you can test them, or they are coming from some endemic areas, then go for it. Other important thing, and especially this also is being seen in young population, which is basically osteopenia or osteoporosis. And nowadays, these 35-year-olds are coming with loss of calcium or calcium deficiencies, especially osteoporosis or osteopenia, and other metabolic conditions, which can be hyperparathyroidism or thyroid conditions. So these patients also need to be evaluated, and especially on imaging, at times osteopenia may not get diagnosed, and you might have to order their alkaline phosphatase and parathyroid hormones and other tests. So metabolic conditions. So any systemic illness can also cause a back pain, and probably they come to you directly with a back pain. In fact, nowadays, we might have seen that patients with viral arthralgias and COVID, they also visited us for back pain, and then they later on developed symptoms of COVID, or they didn't develop symptoms, but actually were the patients of COVID. So you need to get into the lab test or biochemical approach or systemic conditions which can be identified. Now, these are very specific subset of patients where patients have taken multiple treatments, chronic low back pain and normal imaging. Now I'm going to the biomechanical reasons for it. And these are another areas where we need to, put our efforts into. If, let's say the labs comes absolutely normal, there is nothing into it. So the simple conditions which can be lumbosacral sprain, or especially because there are so many ligaments around the lumbosacral area. Lumbosacral strain because of patients, some sports activity repeatedly, his sitting habits, his sleeping habits, probably, or he's working on a shop floor, and any condition that can lead to strains. Other area where we usually don't look into is the pelvic, because X-ray when we do, most of the times it doesn't include, doesn't show us the ilium bones or the pelvic bones, where there is a, either there is up sleep or down sleep based on the, where there is a pelvic sacroiliac joint migration. There is another condition called as pelvic tilt. The patient has anterior pelvic tilt excessively or less, and based on that, the lordosis might get affected. Again, imaging will be absolutely normal. There may not be any change in the lordosis, especially if patient's X-ray is being taken in the lying down position. So you might have to also assess clinically. Also, you can see whether there is a pelvic tilt when the patient, stands. So that is another area where we need to find out whether there is a biomechanical reason. So I'm not talking about only mechanical reason, because mechanical might include, other mechanical conditions like fractures, which can be seen on imaging, but these are the conditions which are not seen on imaging. Ligament laxity, especially those who have hypermobility. And as we know, there's a hypermobility syndrome where the patient's ligaments themselves are very hypermobile, and they get repeated injuries to their sacroiliac joints or lumbosacral joints. And that's where I come to sacroiliac joint dysfunction. This is another area which is most of the times ignored in our OPDs. And there are very simple tests which you can do. Most of the times we do only figure of 4 and then we forget about SI joints. No, there are 5 tests which you can do for sacroiliac joint, including Ganslon's test and compression test and distraction tests, and at least do these tests and find out if there is a sacroiliac joint dysfunction. Of course, the tender point might vary because it may not be exactly on the SI joint. And many times when the tenderness is on the posterior superior iliac spine, it is confused with sacroiliac joint or lumbosacral ligament. So you need to identify the sacroiliac joint dysfunction and differentiate it with the lumbosacral strain or sprain. It's very important to identify sacroiliac joint dysfunction because it can become a reason for a chronic unresolved pain, which can disrupt patient's life because of untreated or repeated treatment not giving any results. Even the physiotherapists many times won't be able to treat that condition, and you might have to go for sacroiliac joint injections or do diagnostic injection first. So another area where you can go into is that if you feel there is a sacroiliac joint dysfunction and you are confused whether it is actually sacroiliac joint or the reason of the pain is something else, sacroiliac joint pain can radiate to lateral side of the thigh, even till the calf, because of the nerve supplies or nerve roots which are coming from there. So make sure that the sacroiliac joint diagnostic block is done. So inject a local anesthesia into the sacroiliac joint, find out if the patient immediately gets a pain relief, and that's confirmed that it's a sacroiliac joint problem. And then you can go for either therapeutic steroid injection or radiofrequency ablation of the sacroiliac joints nerve supply. Another thing is sarcopenia, especially because of the old age, or this can be also nowadays. I have seen a lot of young people coming because of the work from home culture. During lockdowns, they were sitting at home, no exercise, and their muscles, especially in the low back area, or paraspinal muscles became weak, and which is rather the most important muscle that I always test when they are in my OPD is transversus abdominis, where you can palpate the transversus abdominis just inside and below the ASIS. and tell the patients to contract it a little bit, like pull the belly inside, and you can feel that muscle. And after the experience, you will feel that what is the normal strength of that and what is abnormal. So it is very important to identify if there is a generalized skeletal muscle weakness, and which can again reflect into the low back, or specifically for the low back because of again the posture or the way they are sitting and working there. The posture is very important. So you can identify the sitting arrangements, how many hours they are working, if they are drivers, the kind of cars they are driving, the hours, the rest, the stretches, if there is anything that they are doing. So if you go into details of each and everything, of course, there will be pointers which can guide you to something. But if there is nothing coming, then you need to do this step by step. Other area which now, let's say everything comes normal. So I'm going now into deeper, and that's basically a microscopic changes which are not seen on imaging or not in biochemical ways, or we are not able to identify in a biomechanical way, where we don't think that there is any biomechanical abnormality. So there might be microscopic things which are not yet seen on the imaging. And one of the thing is intervertebral internal disc disruption, where it is the early phase of degeneration, where the water content is there, but the breakage of the lamella in the annulus fibrosus has started. And that's where the internal IDD or disc disruption process starts giving pain, because there will be ingrowth of the blood vessels coming from the periphery, and that's where the sinovertebral nerves will get irritated, and patient will get pain, which is mainly discogenic pain, but the MRI is normal. And MRI is normal because the water content is still there, and it is, you don't see that blackening of the disc on the T2 images on the MRI. So IDD, and of course, you can again go with the diagnostic discography, diagnose it, and then treat it by annuloplasty procedure, where you can, ablate sinovertebral nerves with radiofrequency currents. Inflammatory, again, these are enthesiopathies which might be there, and we might be able to catch up them in the lab test. But if, as you know, 20% of the patients with ankylosing spondylitis will have HLA-B27 negative, even if done with PCR method. So there might be such kind of patients where there is an inflammation, there is an enthesiopathy, but we are not able to diagnose them on either imaging or biochemically. Myopathy, and this is another condition which we might have to take a help from our neurologist friends, where they can do EMG studies and find out if there is a myopathy conditions which are coming. Chronic spasm, this is another area where everything is normal, but the patient has pain. Many reasons for chronic pains, especially because of the patient's postures and the alignments that they do while they are working. Myofascial nodules, of course, you can palpate them many a times, but there are deeper nodules, especially in the ligaments, which are not palpable, and triggers which are formed. These are also sometimes the ligament triggers are not palpable, especially in the lumbosacral area. So these are microscopic changes which happen. And that's why many times you will find that these conditions can be diagnosed and treated. But for the nodules, sometimes these people, or you might have seen people offering these local low back injections. And they inject normal saline or at times prolo agents. And after 3-4 injections, weekly intervals, patient gets absolutely okay. Why they get okay? Because the ligaments which are there, they go to the facet joints and the ligaments areas where actually it helps for the healing. If there are triggers, then it will be released. Or if there are nodules, now there is this treatment which is commonly done, especially because the nothing is happening. Orthopedic surgeons tell that go to physiotherapy. Physiotherapists are not able to help with exercise. Then they do something called as dry needling. Now this is another area where actually the muscles where the triggers are formed are released with this dry needling, and the healing potential happens. Then there is no structural change you can see on MRI, but these are the microscopic changes which happen, and they are healed with the dry needling and other needling techniques that are used. Probably acupuncture also might be working on the same way. So after the microscopy, let's say we go for, and again, for the diagnosis of these conditions, you have to have a clinical suspicion and go for diagnostic injection. For example, for IDD, you might have to consider do a discography, and for triggers and other things, you might have to go diagnostic blocks, where you feel there is a facet joint problem. You do a diagnostic facet joint block and then see if there is a relief. So of course, these become interventions. But if the patient has a chronic pain for more than years and there is no relief and everything is normal, you might have to consider this. I'm coming to neurobiology now. Now I have kept this a little late because most of the times when we don't find anything on the X-ray or MRI or imaging, we label the patient as supratentorial. I think we should avoid that and try and find if there is actually some reason for it. And then at the end, you can go and say that, probably patient is a psychosomatic pain. Probably some kind of a mental trauma has happened and the patient is having problem. Many times the chronic fatigue syndrome, anxiety, depression might be associated with, chronic lower back pain. But believe me, fibromyalgia is another condition which is very particular, very specific, which needs treatment and can be treated. Because fibromyalgia is not that the patient has a psychological issue and he is just needs a psychiatric treatment, but he needs a proper treatment for fibromyalgia, which includes multidisciplinary approach, where you need exercises, you need a psychological counseling, you need tablets, we need vitamin supplements, mobilizations and exercise, ergonomic guidance, massages, at times Ayurvedic treatments, and they do really well. So by just labeling them as a psychosomatic, it doesn't solve the problem of the patient, and even it won't solve the problem of yours, because you will be just thinking it's psychosomatic, and probably you will be referring them to multiple places, but the patient will not get a relief because he needs a perfect diagnosis first, and then based on that, a multidisciplinary treatment approach. Other condition is neuropathy. You might have also come across patients of neuropathy coming to you as a back pain. Recently, I saw a patient 2 days back, Hiramaya's, of course, that happens in cervical spine, Hiramaya's disease, where he was an avid gymmer, going to gym every day, and he had this severe neck pain and not able to find out anything on MRIs and everywhere, and where actually he started getting weakness and all that because of the pain. He didn't know what to do. So when we did actually his NCV studies, we could see there is anterior horn cell degeneration which is happening, and it is very common seen in people who do very heavy gymming because of the continuous flexion of the cervical spine. And similar anterior horn degenerations can also happen in lumbar spine. So neuropathy is another condition which need to be identified. Now, why these patients get excessive pain is because the ascending pathway facilitation and descending pathway inhibition. So the pain which is carried is basically substance P, nerve growth factors, and glutamate, and the inhibition pathway, which helps it to basically reduce the pain sensation, which is serotonin, dopamine, and other factors. So in case of fibromyalgia, it has been found that in CSF you will have increased level of substance P and glutamate, and the reduced levels of inhibiting chemicals, neurochemicals. And that is the reason why they get pain. So there is an actual reason why they get this pain. It is not just in their mind, but there is our chemical changes which are happening in the pain pathways, and there is a hypersensitization of these pain pathways, where they get, let's say there is a pain, there is a physical problem, but actually they perceive it very excessive. So there is a pain, let's say normally it should cause a pain on VAS scale from 1 to 10 only 2. But the patients who have hypersensitization, they will perceive that pain up to 8, 10, even you touch them and they will be like, I can't just bear this pain. So make sure that you identify whether they are actually having a psychosomatic issue, or there are some diagnoses which can be there for neurobiology. Now, after everything is normal, you also need to look at the surrounding pathologies which can be there in central nervous system, like patients with at times, in fact, patients with Parkinson's or some other conditions, degenerative condition in the spine, brain can also present with a generalized body pain and a back pain. Cervical myelopathy, at times, cervical spine condition, everything is fine, but the patient has only back pain and radiating to lower limbs. Hip conditions can, and there are many other areas. Other thing which I want you to understand is a neuralgia, and why I wanted you to see the patient's back when the patient is complaining back. This is a condition where the female was there and she was not very comfortable showing me the back area. Of course, I called my I always have a female assistant with me when I'm examining a female patient, especially in the low back area, and that's where I could see that she actually has a herpes, and she didn't know that because it's of old age and she just has a back pain. And even before the rash comes, the patient starts getting pain for 3-4 days, and then the rash starts, and then everything starts. But after this rash is over, which is acute, patients might land up into chronic neuralgias, and that leads to the back pain. And that is where we are here right now. So patient might have got a herpes, got treated, nobody knows she had actually herpes, and then, or she might not have got treated, got self-healed, and patient has a neuralgia. So going into details of the history as well as examination is very important. Sacroiliitis is another condition where it can present like a disc or even radiating pain to the legs. So you can look at the surrounding areas. And the last, which I want to not forget, is malengineers, because these are some people who have some self motives or selfish interests to always show that, I have a pain. And again, I don't have to tell you who these guys will be, but there are, Wardle signs which you can test this test and you can find out whether the patient is malingering or actually has a, actual pain. So I will name these little different from actual psychosomatic, because psychosomatics will have actually an issue, but these patients don't have an issue, neither in the neurology nor in their pain pathways, but they actually are just trying to fool you around so that they can get a leave or, do something with their life. So these are main conditions, approaches, and issues that you can identify for the patients who have chronic low back pain, but the imaging is absolutely normal. So you can see the chronic low back pain is multifactorial, and especially those who have absolutely no findings in imaging, they can have multiple reasons for it. Now, many a times, because of the lifestyle that we are going through, the aging population, you will always have something on X-ray or MRI. But please remember, that may not be the actual reason for the pain. That may be just associated or, the finding in the MRI. As we know, if you do the MRIs of 100 people, you 70, 80% will have some kind of a disc or some kind of a degeneration in their spine. Doesn't mean that they have pain, or doesn't mean that the source of their pain is from that pathology or that the anatomical defect that you have seen. There can be anything which I just spoke about, and we need to identify that and treat that. And the best treatment for that is actually considering that pain is not only because of the, let's say there is a compression of the nerve root or the disc degeneration. It is also perceived in the mind, and, any psychological stress, for that matter, even people who don't have psychiatric illnesses but is under stress, will lead to aggravation of the or sensitization of the nerves and will lead to more pain. If that is not treated, again, more stress, more pain, and they'll end up into this chronic pain cycle. So it is important while you are treating approach. So that's what I follow at my clinic, spinalogy clinic, where we do multidisciplinary treatment, where we involve different specialists, including, of course, orthopedic and some injections if required, nutritional counseling, stress management, if required, complementary therapies, which can have massage, Ayurveda, ergonomics, which is basically postural therapies, mobilizations, manual therapy, physiotherapy, and all this based on what condition patient is offered to him. And especially those who have psychosomatic problems, they will need multiple of these treatments and multiple doctors involved in the treatment of them. There is enough evidence which is shown to, which has shown that multidisciplinary treatments absolutely fantastic for the patients with chronic low back pain. This is my own paper which was published. Since I'm just overshooting my time, I'll just skip these slides so that we can go to discussions if there is any. This is another paper which are published where we, this is not for chronic low back pain with normal imaging, but this is for people with slip disc having radiating pain, where multidisciplinary treatment worked absolutely fantastic for these patients and excellent results with them. So in summary, chronic low back pain is very common, especially those who have no changes on their imaging studies. Need to investigate, find out if required, do diagnostic procedures. Remember that it's a multifactorial etiology, needs a multidisciplinary treatment. And of course, the treatment is evolving. You might have to involve other people in the treatment. And there is no magic pill or magic treatment which can fit everybody, especially those with chronic pain. So that's what I wanted to talk about. If there are any questions, I'll be happy to answer.
Dr. Kiran.
Yes, sir.
Any questions for Dr. Kiran?
Dr. Kiran, thank you for this wonderful talk. But can you illuminate also on the topic that an orthopedic surgeon should be able to read an MRI of a spine? Because the MRI described by a radiologist is altogether speaks of in a different tune. That we are not able, a person who cannot read an MRI is totally at the mercy of the report. So what we are talking about, that because the MRI has become a household investigation like X-ray in the past, so there should be classes how to read a spine MRI, because so many spine MRI which are said to be pathological are practically normal. So that gives a very and the patient is being suggested surgery or different modality of treatment, which it is most of the doctors are not agreeable. So what should be done in these cases?
So in case of MRI is my honestly is the last investigation that I consider. But if I'm going to do MRI, and usually when I send my patients for MRI, I write down what is exactly that clinically I am suspecting. Because sending just for MRI, the radiologist has no clue what exactly is being done. Usually, if I'm sending to the centers in my area, they all know, and my radiologist and I usually talk for almost every day for discussing any report of the MRI. If I'm going to patient is going to go anywhere else, then or otherwise also, I write down that I am suspecting L4-5 disc and probably compressing on the right side, and that's where things are going way bad. Or if I am suspecting stenosis or facet degeneration or anything, tumor or whatever in my mind. That is one. Secondly, we need to get trained in reading basic MRIs. I'm not saying we should be experts into it, but we should be able to, because many times I have called my radiologist and told them that you need to change this diagnosis, you need to change the report, you need to identify there is a paracentral disc, there is a extraforaminal disc, or can you see that there is something else going on here? And I have been fortunate enough to have radiologists who actually relook at the things and then they change the reports. We need to get basically trained into reading primary things on the MRI. We don't have to be experts into it, but we need to be updated about it. That's for sure.
Thank you. That's exactly what the message is, that you should be primarily able to read the MRI and then read the report. You first see the MRI, try to read the MRI, according to the clinical findings and correlate the MRI findings with your clinical findings, and then look for them. So this is what the radiologist is not aware of. What are the clinical features? He has not seen the patient, he has not examined the patient, he does not know about the complaints of the patient, and that is the reason he is reading a piece of reflection, and we should be giving him proper detail that what has to be seen and where we are concentrating on. That's exactly where there is a communication between the clinician and the investigator, of course. Thank you, Kiran.
Thank you, sir. Thank you. Sir, are there any questions from the audience, Dr. Ashok?
No, I have not seen.
Okay, sir. Okay.
Thank you, Dr. Kiran. So the next talk will be splints in hand, how, where to use. So there are so many splints available in the market. Whenever you write a finger splint, they get some frog splint or something. And this is an age-old thing where we do such kind of strapping of finger. So usually nowadays what it is said is we should not do this strapping. Now if you see our fingers, they are not at same level. The joints are not at the same level, and because of this we might get stiffness into the other finger also. So strapping should be a big one. Then there are some other types of bandages, sort of ball bandage or something like that. Again, this has to be avoided. And this another problem where a plaster is been applied on the volar side, and the metacarpophalangeal joint is in extension, wrist is in slight flexion. So these things are to be avoided. what is needed is the MCP joint has to be flexed, the wrist has to be extended. So this is the James position which has to be. So nowadays it is said that instead of a volar slap, we always go with a dorsal slap, and that usually maintains that James position. Or if we are going for a volar slap, it should not cross the distal palmar crease. So that is what is needed. Again, this type of cot splint or something. Now, if we see, this splint is extended till the MCP joint. So the movement of MCP joint is also blocked. So this type of splint is not advisable. And many times what happens is this strap, they press it so hard that the the blood supply at the tip of the finger gets affected. So we should avoid this type of splinting. Another important thing is elevation. So the injured part should be always above the heart level. The cuff and collar thing, what is been told is the cuff part of the button should be attached to the collar part of the shirt. So that is cuff and collar. So usually it has to be above the heart level. So this position is not acceptable. So what should we look for a finger or hand injury? So always see for uh, ask them to flex the fingers. Whenever you do this, so all the fingers they point towards the scapula. So this is called the normal cascade. But if there is scissoring like this, right, or there is some shortening, or there is pseudocloy. So this is sort of a pseudocloy, something like this with this fracture. This needs surgery. So we should go ahead with the surgery. And now, what types of splints? So there are static splint, there are dynamic splint, there are hybrid splints. So we just go one by one. So what is the use? So it is used for fracture healing. We can use for a corrective purpose, supportive, protective, then strengthening of the muscle group, relief of pain, and facilitate motion.
Hello. Galat number.
Now this is an outrigger splint. Where we use this aluminum splints. We can make it in our own clinic, and it is very useful. It can be used in a static way as well as a dynamic. Just show you. So here we have applied this aluminum splint on the dorsal side, and this is that suction tip. These are all very cost-effective splints which can be used, and patient is encouraged for mobilization. So the main purpose of treating hand fractures is to give a mobile hand. So many times we come across with a lot of stiffness. The movements are at risk. So for that we should go for dynamic splinting. So this is the way we apply. We take it as that aluminum splint. We keep curve upwards, and then you can use whatever way on the volar side, on the dorsal side, whatever is the need of the patient's hand. Accordingly, we can use it. Again, over here we can see that it has been applied on the dorsal side, and for the ring finger, we have applied additional splint. So again, that this is the way in which it acts as a dynamic splint also. So a rubber band is applied along a pin, and patient can move it and do the exercises within the tolerance of the patient. Yes, again. So these are all cost-effective things, because every time patient may not afford the company braces and this, but here we can give. So here you see there is a small rubber band. This is basically of the gloves, so it holds it in flexion, and we just remove that band and ask to extend. So we can do a dynamic splinting. Again, we can see now here. Yes, this is that gloves which is used to cover inflection, and these are the rubber band. And we remove the gloves and ask to extend, and again. So this is done every hour. So with this, the stiffness part of which is the main problem in treating hand fractures is almost nil. Yeah. So this is the gloves which has been cut, and now whenever there is a metacarpophalangeal joint flexion, so again very simple thing. So we have just used a bandage, a clip, and these are again gloves, and these are the rubber bands. So they can do the active flexion as well as passive. This is easily available in the market. So again, we can just use it to do the finger exercise and get rid of stiffness. The gloves part, we just give them the cut part of this gloves like this, and ask them to do this flexion exercise. So that does really work for stiffness. So these are the other splints, cock-up splint, where it is used: unstable wrist joint, wrist sprain, tendinitis, distal radial joint injury. So what is the objective of this splint? A passive wrist extension, active wrist flexion, prevent contracture of unopposed innervated wrist flexor. So now we are going towards the nerve injuries. Now here, this is used for ulnar nerve injury, which leads to clawing of the ulnar fingers. And this type of splint, it prevents that thing, clawing, and it stabilizes fourth and fifth metacarpophalangeals in flexion, and it corrects fourth and fifth metacarpophalangeal hyperextension. So it does exactly opposite of clawing with this type of splint. Now, if we have a median and ulnar nerve injury, this kind of splint helps, and it will take care. So it gives a complete claw hand. This is very useful splint. So in all your DIP joint injuries, so this is a Kapner splint. So it gives a good, so that you have a spring over here, so that they can do this dynamic movements along with. So for your DIP contractures, DIP flexion contractures, toenail deformity, this splint is very useful. This is a Zimmer splint, which we are using nowadays for DIP fractures and dislocations, and a mallet splint. So in this mallet splint, what we want is a hyperextension at the DIP joint, and the DIP joint should be able to flex it. So this is the way we apply it. So instead of using those squat splints and the splints which I showed earlier, this is the best way to immobilize a mallet finger. So we do some hyperextension at the DIP joint, and then we use two straps so that the patient can do DIP joint flexion. That should not go into default. So this is the way we apply. So these are the other splints for the mallet finger. This is an interesting splint, J splint. So whenever you come across a patient with fingertip injuries, and there is a bulk fracture or a distal phalanx fracture with a wound around. So in those cases, we can use this kind of splint. So this is sort of a dressing applied, and then this is the J splint. So it just comes at the DIP. So this is the way it is. Yes. So they can even do flexion at the DIP as well as DIP. This is a J splint. So very useful whenever we come across the injured fingertip injuries. Outrigger splint, again we use this. So this can be made in our own clinic. So this is an aluminum splint, and this is a cushion along that aluminum splint, and we can make it. It is a malleable thing, so we can make it of whatever shape we want. So like this. So with this on, we put a plaster and the short arm splint. So during plaster also, whenever we are applying a slab, so we make a center sort of this thing, so that the plaster becomes 4 times stronger. It doesn't break. So I'll just show you. So this is a slab, and this center part we just do like this around it. So doing that, it makes the plaster very strong. This is applied. This is applied. Now ulnar gutter splint. Again, so see the position of hand. There is extension at wrist joint, there is flexion at MCP joint, and the IP joints are extended. So there is a slab on this side, and there is a slab on this side. This slab, it ends over. So your boxers fractures, your fifth metacarpal, fourth metacarpal fractures, this is a so like this, it is applied. This is the dorsal side. Thumb spica again. So we just apply on this side, and again we can see that ridge which is being made. So that makes the plaster very strong. And after putting a slab, I always give a crepe bandage. The advantage is the plaster looks good. It doesn't get soiled, and the bandage which we use, it becomes thready and it comes out easily. But if we use a crepe bandage over a slab, it maintains it in a fashion. This is thumb spica. Sugar tongue splint. So this is also a very useful splint. So there is always a debate, should be given above elbow or below elbow, cast, slab for distal and radius fractures. So this is a splint where we can, it gives answer for both the things. So this is the slab, this is the ridge which is being made like this, and it should not cross the distal palmar crease over here. And then it goes like this along the elbow, and it covers, and so you can immobilize the wrist as well as the elbow. Fracture dislocation PIP joints. So PIP joint injuries, many times what we see is we give this body strapping and very casual approach, and it's like nothing, don't worry. And many times what it is seen is these 2 X-rays are done, an AP and oblique. So these 2 X-rays, usually we miss the fracture. What we want is a true lateral X-ray, so that you can see the joint of the PIP and become a diagnosis. So this PIP fractures, if it is less than 30 degrees, they are stable. So over here it is stable. Then this is quite unstable. So if these are the fractures and if there is a dislocation, it has to be treated. So there are so many options available, like extension block, splinting, pinning, so many things. So what we follow is, if the patient comes early, let's say within 10 days, we use this Zimmer fixed traction technique. This works. This really works. If the patient comes late after 2 weeks, then a Suzuki frame, yes, that also. But if the patient comes very late, let's say 2 months, 3 months, and then he has a lot of stiffness, no movement, pain, then we can go with a volar plate arthroplasty or hemiarthroplasty. So extension block pinning. Then these are some of the other methods. Like, but then there is patient doesn't keep this. Then there is something called extension. These are all splitting methods, but this is only done when the fracture dislocation is made. Zimmer static traction. This we are using nowadays whenever the patient presents early. So this is fracture with dislocation. B sign is positive. That means there is subluxation of the joint, and even the patient had some fracture at the third metatarsus. So we use this aluminum static splint nail traction. It is done under local anesthesia. Splint is used for 3 weeks, and then we give a splint, other dynamic splint for a week, and then so this is the way we do. So we are here. We are giving a tendon sheet block. So at this. So usually our digital now comes like this, goes here like this. So if we given 2 ml over here, we can do get a good anesthesia. Then we take a 1-0 stitch in the nail bed along with the bulb. Further, we make this aluminum splint and incorporate this aluminum splint in a plaster. And now we are fixing so this is the fractured finger, and this is the splint, Zimmer static splint. This is the final construct, and this is the extract. So nice reduction. So we keep this splint, static splint, for 3 weeks, and once the fracture becomes gummy, then we start all the mobilization techniques we can. So this is after the removal of the splint, we give such kind of a dynamic splint and take the early mobilization.
It's over, no? Once it's over, you go and change, and then you help me get things down.
Now we couldn't. I want to ask you.
Yeah. So this is what is the message. So there was Dr. Paul Brandt, the famous Paul Brandt of CMC Vellore, who had devised brand transfer. So during one of his lectures, he had a 1 hour lecture, and he was keeping his hand like this. Throughout the lecture, his hand was. So after the lecture, somebody asked him, why are you keeping the hand like this? So he said, if you don't understand anything of my lecture, if you just understand this thing, that the hand is to be kept in this position for immobilization, that is enough for it. So that is what is my message. Intrinsic plus position, James position, whatever we say. So 70° of flexion of MCP joint, 70-90 degree fine. IP should be fully extended, and wrist should be slightly extended. So this is my OPD, where I prepare my own splints and do this splinting in my own clinic. Thank you very much. Hello, and any questions? Aroop sir, you are online?
Yes.
Okay. So for the next topic, I invite Dr. Aroop Mukharjee. You can also use DMARD in rheumatoid arthritis in OPD. Please take over.
Am I sharing the screen and am I visible and audible?
You are visible, audible, but screen is not visible.
You are audible, you are visible, but screen is not seen.
Just a minute.
Sir, you have an option of share screen.
Just a minute. Share screen. Share screen. Yes. Can you see the last share screen?
Not yet, sir.
No, sir.
Not yet. Is it now visible?
No.
Just a minute. Share screen goes positive. Is it visible now?
No. Sir,
No,
you
sir.
will also be able to see once your screen comes on the.
I can see my screen, but it is not visible to you all.
Sir, again go back. Go on share screen.
Yeah, I am just clicking the share screen. I am clicking the article. Share.
Yes.
Is it all right?
Yes, sir. Yes.
Yeah.
Okay.
Thank you. See, thank you, Dr. Ashok, for your wonderful presentation in hand splints. And hand has been my subject of interest for more than 35 years. So I could understand what your message is. But, and again, thank you so much for putting it in such a lucid way. So now I will be talking about the rationale use of DMARDs in rheumatoid arthritis. Now, there always been a controversy, or there has been a word like osteoarthritis versus rheumatoid arthritis. Now, arthritis is a chronic inflammatory disorder of varying intensity and unremitting in rheumatoid arthritis, where osteoarthritis is also a chronic disease with intermittent acute phase. As we all know, it is the osteoarthritis patient who is intermittently well and intermittently is in trouble. So this is what the clinical picture is. But both of the group of the patient suffer from an inflammatory disorder of non-infective nature with intermittent flare-ups. And when the patient comes to the doctor, most of these patients have had this experience in the past. Now they have come to a new doctor or the old doctor who has been able to put his inflammation under remission in the past, or he has come to you with the expectation that you will do it for him. Now, to my definition, there has been a lot of confusion in deciding this is osteoarthritis, this is rheumatoid arthritis. Now, rheumatoid arthritis being more of a systemic disorder and osteoarthritis being more of a regional disorder, but both are inflammatory in nature. Now, genetic inheritance dominates osteoarthritis also. Osteoarthritis can be put under remission by regular exercise. Whereas rheumatoid arthritis needs regular medication as well as exercises. What makes the situation worse is the moist and a cold weather exposure, repeated injuries, and exposure to viral infection. An osteoarthritis patient or a patient who has got backache or knee pain, a spondyloarthritis patient, will get flare up after a minor whiplash injury or a minor sprain of the back or with viral infection like chikungunya or COVID-19, like that infection. So the message what I want to say, that in our population, there are arthritic patients whose arthritis is sleeping or whose arthritis is wide awake. My effort is to put this active arthritis into inactive arthritis. And we can never cure this patient. That is the reason the word remission is being used, so that this disease goes into remission, that means inactive stage, and then the patient can maintain the remission by doing regular exercises. Now, what is the diagnosis? Arthritis is a systemic autoimmune disorder and will seldom come alone. So when there is an autoimmune disease, this is arthritis, ulcerative colitis, and bronchial asthma are three major autoimmune disorders. A major autoimmune disorder will never come alone. When we see in our OPD, you see this arthritic patient, look for other autoimmune disorders like hyperacidity, hypothyroidism, hypertension, dyslipidemia, diabetes, obesity, and in children of arthritic patient, girl children, they suffer most commonly with PCOD. 50% of arthritic patients have lupus disorder, and nearly all SLE patients have arthritis. What is a lupus? Lupus is an inflammatory disorder of the blood vessel, and blood vessels are supplied to all the vital organs of the body. So the neurologist is fed up of lupus, nephrologist is fed up of lupus, the cardiologist is fed up of lupus, and we the lower limb has got inflammatory disorders in the lower limb that leads to clotting of the blood vessels in the lower limb, and this affects the heart, brain, and the kidneys together. See, this is the patient of an arthritis who has got venous thrombosis in the foot. The color of the foot and the color of the leg is different because there is a static blood thrombosis in the foot. And when I treat these patients, the thrombosis resolves and the color of the foot will also turn normal. See, this is a systemic effect of lupus. We call it as a melasma. When I treat these patients, so the minor autoimmune disorder, they get corrected by themselves. I don't have to give any separate medicine for them. This woman who has the right side picture, she came in this condition And when I started treating this woman with my low dose DMARD, see how the color of the facial skin has started developing to a normalcy. So melasma is an important sign of an arthritic patient as an associate symptom. So I cannot miss these signs in an arthritic patient. See, again the same thing. This is a deformed foot along with venous thrombosis and discolored dorsum of the foot. So most of these patients, you will see that hypertensive patients, they have dark color skin of the leg and the foot and their feet. It is because of venous or vascular thrombosis in the lower limb. The lower limb being staying below the level of the heart develops more thrombosis, and if this stays for a longer time, due to the deficiency of calcium, they develop varicose veins, and then they develop varicose ulcers, and then it becomes a non-healing ulcers, which is a challenge to any clinician. So just I will be describing you what are the associated problems of arthritis. Associated problems by which I can clinch the diagnosis is anemia, hypertension, vitamin D deficiency, or because anemia, hypertension, and vitamin D deficiency are associated with the renal involvement in the arthritis, that is the lupus. 50% of arthritic patients have lupus disorder, and the kidneys are affected, the liver is affected, and when the kidneys are affected, which leads to anemia, hypertension, and vitamin D deficiency. So when I correct this arthritis business in a patient, anemia corrects, hypertension settles, vitamin D deficiency comes to nearly normal, although I have to inject or give associated vitamin D supplements, and the patient improves in many factors. The chronic lupus disorder causes permanent atherosclerosis and associated life-threatening emergencies like stroke and CVA. So arthritic patients are, especially men, are highly vulnerable to cardiac emergencies like heart attack or strokes. So whenever I see an arthritic patient who has a sedentary lifestyle, who has been complaining of backache for a long time, and who has a blood pressure, who has dyslipidemia, I send them first for a TMT to my cardiologist associate so that a impending heart attack can be ruled out in men especially, but women also suffer from it, though in lesser frequency. What is the role of DMARDs? My way of giving DMARD is a way in which I can limit the activity of the disease for decades after I have diagnosed the problem. This limits the hyperactivity of the autoimmune disorder, also reduces the general immunity. Then all autoimmune disorders are not equally severe as arthritis, like diabetes, hypothyroidism, blood pressure, acidity. These are autoimmune disorder, but not as intense as arthritis or asthma or ulcerative colitis is. These can be managed by individual medication, like taking hypertensive medicines and a thyroid supplement, but automatically. So when you correct arthritis by DMARDs, all the minor disorders get corrected or get modified, like we see in diabetes, hypertension, hypothyroidism, which are commonly associated with arthritis. Why I commonly use DMARDs? These are age-old, well-practiced DMARDs. We know their side effects, we know their dosing schedule, and we can manage and identify their adverse reactions much before by simply looking at the blood test. So these are the 5 commonly used DMARDs in my prescription. How an orthopedician is concerned, one cannot separate orthopedics from rheumatology. Why? Because most of the orthopedic surgery is addressing chronic degenerative disease of joints and spine. Why there is a degeneration more in some patients, some person, there is less degeneration in some person. That is a matter of genetics and genes, and it's the penetration of the genes. We inherit arthritis from our generations, but our lifestyle makes the gene more penetrable, and the manifestation of the disease is more common in a sedentary lifestyle, in a malnourished person, or in a person who is moving where the pollution is at a higher level. As a true specialist, one should be knowing the preventive aspect of the disease and its pathogenesis. So it may be, but when a person goes and asks, how can I prevent a joint replacement from a joint replacement surgeon, it is a laughable thing, because the joint replacement surgeon's main income is from replacing the joint, and you can't ask a joint replacement surgeon how to prevent the joint replacement, which is his bread and butter. What is a safe regime of DMARDs? Now DMARDs are fought with certain amount of fear in clinicians that it may cause into side effects or adverse effects of the DMARDs. But a regime should be that safe that merely on a suspicion of an autoimmune disease, you can start the regime without causing serious side effect. That should be the hallmark of a safe regime. That means after the basic blood test, X-ray and ultrasound whole abdomen, one can give a therapeutic trial of the regime and see the response after a month. So this has been my hallmark of the treatment, that I don't go into very major blood test like getting anti-CCP done, or even getting so many other expensive tests and pathological tests, because these pathological tests are positive today and negative tomorrow. And it is very difficult to say that in spite of all these tests, there are hardly any test which can bring all the patients suffering from a low-grade autoimmune disorder or arthritis into a diagnostic net. My recommended regime does not contain any painkiller. I never give painkiller to my patients. The relief is beyond doubt about the diagnosis. If my diagnosis is correct, the patient will get relief in the pain within a month. That confirms my diagnosis, because minor arthritic patients never come as seropositive patients. Now, Mukherjee's regime is what? Mukherjee's regime is a combination or a cocktail of many disease-modifying drugs in a very moderate and a minimal way, so that none of the drug causes any significant side effect in the patient. The patient has to be tested for basic blood test. and an ultrasound whole abdomen to know what is his status before the treatment. This is what I give for a seropositive rheumatoid arthritis. Means those, at least the patient who are at least seropositive, they should get the treatment like this for at least 3 months. And in my experience, where I have written more than 6 lakh prescriptions on the same mode and same pattern for all India patients, they behave very well with this treatment. But I keep a touch with my patient so that in case they find any trouble, they get back to me. But rarely I have found that the patient within a month has come with a particular adverse reaction. So this is what, that this is a combination, because most of these medicines are either synergistic to each other. So synergistic medicine has to be given on one day, antagonistic medicine has to be given on the next day. Synergistic medicine are given on a particular day like Monday, Wednesday, Friday. Antagonistic medicine has to be given on next day like Tuesday, Thursday, Saturday, so that the reactions of one drug is not neutralized by the other drug. I think most of my most of the persons who have heard me speaking on this, they might have got a copy of this with them, and they can realize that what is combined with what. And that is the reason this combination is a highly successful recipe for most of the arthritic patient, even if they are suffering from so-called osteoarthritis. In my definition, there is no separate chapter for osteoarthritis or rheumatoid arthritis. Both are autoimmune inflammatory disorders of musculoskeletal system. One is aggressive, where it is seropositive. I tell that the patient has to be on the medication for the rest of her life, and which is seronegative, they can be off the medicine after a while, and again they will have to start the medication, or they can continue their treatment on a low dose recipe. This is a low dose recipe in which you see that the Folitrax or the methotrexate is only given twice a week, and supplements are, and the other medicine are also given accordingly. So a low dose medicine is what we can call as a top-up doses after a 3-month period. I'm telling you that my patients are on these medications, whether they have come to me as a seropositive or an aggressive arthritic patient, but they are on this medication for years together. Although for safety purposes, I always say that they have to come and get their blood test every 3 months. See, this is the classical example of one of my patients who came for another side knee replacement. I said, well, if I can go for a smaller surgery on this side and keep you on this medication, you can avoid surgery like a knee replacement you had been through on the right side. So 3 years down the line, you see that proximal fibular osteotomy and my low dose DMARD is maintaining the disease activity at a very low level. Patient is very happy as she can bend the left knee and it is absolutely pain-free. She is more confident walking on her left knee. She puts the left knee forward to go to the stairs because she gets those proprioceptive feeling of pressing the knee or the steps of the knee of the stairs, and she is more confident in stepping down as well by the left knee rather than the right knee, which is proprioceptively dull. There is no feedback to the brain about the proprioception which we feel in a normal joint. My regime in osteoarthritis, followed by physiotherapy exercises and diet preference and restriction. I don't look at the X-ray for the joint degeneration, only do PFO or proximal fibular osteotomy, high tibial osteotomy after a few months of regime to correct the alignment of the limb. See it for yourself, the dramatic relief in not only the joint pain, but also the general well-being and improved effort tolerance of a debilitated patient. Future management, medication for a lifelong with adequate supplements, intermittent blood tests are to be done, once a year ultrasound whole abdomen, BMD DEXA to check that the patient is not losing calcium or bone density, regular exercises, encouraging walks, 2 to 3 monthly visits to the doctor for blood pressure, weight monitoring, self-motivation by talking to other patients who are recovering. This has been my sheet anchor of treatment for the patients I practice. So, office orthopedics contains those therapy or those management which can deliver whatever you promise to the patient for a long time without taking any risk about the patient. Arthritis is a disease which is not sitting in the joints. Pain may be in the joint, but arthritis is a generalized disease, and reversing arthritis means the patient general well-being is also considered. See, this patient came with a badly deformed hand. 1 year of therapy, the patient does not want any surgery. See the boutonniere deformities, but the flexibility and the painless mobility of the hand, this is the way. This is only 1 year. And when they continue with the treatment, this woman was able to make dough. She could make chapatis, she could cook, she could stand from a wheelchair bound state to a active member of the society, of the family, who is contributing to only, not even to her own health, but to the hygiene of the entire family, of the diet of the entire family. This is a highly prevalent condition in any society, and many of our friends, neighbors, family members are suffering from it. So ill informations, myth, ambiguous treatment is being sold by commercially motivated pharma companies. OTC ointment, lotion, balm sell the tune 200, 300 crores annually, involving cinema actors, players and doctors to promote the sale in their advertisements. So this is what is mobilizing the pharma companies to make more and more OTC products in the form of ointment, lotions and balms. See, this is an osteoarthritis patient. This is 2/5/2019 and this is 5/11/2021. In 2 years, see the recovery of joint space. It is never taught in our textbooks that a joint space will ever recover. And I am showing it to all of you with proof to see that this is the condition in which the joint came to me, and this is the condition in which my regime got back this patient. I have not done any surgery. You see the fibrocartilage developed and the joint fully moving. I have in my list patients who are been on my medication for the last 20 years, 25 years. The maximum is 32 years. And they have never complained, God forbid, of any complication due to medicine. So the primary thing which I want to convince my listeners is the medicine is safe, but we can't keep our safety profiles to go to sleep. We have to, whenever the patient comes, I always insist on basic blood test, CBC, ESR, CRP, SGPT, creatinine, that's it. If these parameters are all right, once a year ultrasound is all right, once a year bone density is all right, in women of course, then my therapy is going well, patient is happy, patient is thankful. Only I am at loss of monetary funds from the patient, that is true. But my patients are very thankful to me that aapne mera operation bacha liya. Everybody will suggest this lady to go through a total knee replacement, which I have delivered in this stage. What we need is a safe regime which can be used in our day-to-day patients with minimal diagnostic supervision and no painkillers. No painkillers. I never give my patients a single tablet of even crocin. See, this is another patient in which you see there is a recovery in the bone density. The bone density here in 2019, 15 December is 0.837 in the spine. And here in 2021, it is 899. That means after 2 years, although the patient has aged is more by 2 years age, but the bone density has improved because of my regime. Not because of my regime, because I have been able to reverse the disease which was causing the osteoporosis, not her old age. She's 75-year-old, but at age of 73, she has started reversing to a better bone density at the age of 75. This is a proof. This I call as Dr. Mukherjee's sign. See, this lady has got erosion in both the SI joints and the bone adjacent to the SI joint. Is a woman is highly vulnerable to the SI joint secretions which collect at that area, is because sacroiliac joint is a synovial joint. In a woman, they are the size of a palm, and both the joints secrete in inflammatory condition. They secrete inflammatory synovial fluid which erodes the bone, and the area which I have marked indicates that it has eaten up the iliac bones on both the sides. This is a highly classical sign which my students and my followers say as Dr. Mukherjee's sign. If I see this sign in my patients who is complaining of backache or knee pain, especially women, because SI joint is secretory in women, but facet joint is secretory in men. So is this a sign which is Mukherjee's sign, which says don't do any investigations. She is a declared case of spondyloarthritis and start your regime. I don't subject this patient to any money-letting investigations. See, this is what I see in an everyday practice. I see about 30 to 40 patients every day. And this I see in my patients who have been suffering from arthritis, and I don't subject these patients to any blood tests, any serological tests, any expensive bone scans or any MRI and blah, blah. Just see this and start my regime, and you will reap the rich dividends. See, this spine is a degenerative. This is not a degenerative spine. The discs have burrowed inside the vertebral bodies. The end plate has eroded. The disc has gone there. Why? Because the inflammation causes the disc to soften. And this is the disc which is vulnerable to prolapse. This is the disc which goes inside the spinal canal and presses the spinal root. But why does this disc happen like this? Because this is the site of inflammation. So if I see an MRI, I can see various levels of water retention, inflammation in this spine, and this is a site of chronic inflammatory spinal arthritis, or we can say spondyloarthritis. My patient will respond to this, my DMARDs, and will be very grateful to me for the rest of her life, because everybody will try to convince this lady to get this disc out or that disc out, but that is not the end of the story. So they always say that they continue the medication and you will never go to a knife-happy surgeon. See, this is a classical picture, again, in which there are osteochondral fractures. And these osteochondral fractures, I was listening to a talk of Sanjeev Bhandari or probably Choudhary, who was telling they inject outside the joint. But these are the painful joints. This is the painful joint where their attachment of the medial and lateral collateral ligament, you see at the femoral lateral collateral ligament, there is an erosion of the bone because that is the inflammatory site for the lateral collateral ligament attachment. And that also erodes the bone, indicating that this is an active inflammation going on in this joint. Thrombosis of the blood vessel, which is a hallmark of osteoarthritis, causes osteochondral fractures. And these osteochondral fractures, they float in the joint, in a bigger joint, as loose bodies, and they get entangled now and then, causing more and more damage and inflammation, which we should see that they are suffering from arthritis, and the thrombosis of the subchondral vessel leads to osteochondral fracture. So fixing this osteochondral fracture with the help of a pin and this blah is not worth taking the effort. See the associated problem of arthritis. You see that the rheumatoid nodules are there. Whenever you see a rheumatoid nodule, I don't even go for a serological test. She is rheumatoid positive. A RA positive, a seropositive patient, a rheumatoid patient, a patient with nodules is always seropositive. So if I see nodule, I palpate. These are the sites which are very commonly seen. It can be seen in the sole of the feet also. It can be seen in the extensor aspect of the forearm. And the patient will herself tell that these are the nodules which are painful. And when you give my regime to these patients, the size of the nodule and the tenderness also diminishes. These are the focus areas of inflammation surrounded by round cell infiltration as well as few giant cell, which are very, very classical of rheumatoid arthritis. So I, as a hand surgeon, when you send your, suppose you have operated a decurvance disease, you send a piece of synovial tissue to the pathologist friend, they will say that this is also rheumatoid. When you send a piece of A1 pulley, which has been causing triggering to the finger. Then they say again it is a round cell infiltration and a rheumatoid. They say not that the specific language is non-specific autoimmune inflammatory round cell infiltration. So these are all autoimmune disorders, and injecting an autoimmune focal area with steroid reverses the problem for a time being. If you have got multiple areas, then we can't keep on repeating. That is a systemic problem. One has to give my regime, which is safe, and I can promise that this is being used by the feedback of thousands and thousands of patients in a way that it has come today in this form. These patients, especially women, have given me suggestion how to make a particular recipe, as a woman are very particular about cooking their meals, and they have their story about their particular recipe. So this, my regime, is a feedback from those thousands of women to whom I am very thankful, because their feedback has given the prescription in this form that it is safe today. I can advise my friends and colleagues all over the world to use it and see the results themselves. I am not selling you anything worth even a rupee from my pocket that you buy this or you buy that. It is a system in which you can learn these things and deliver well-being to your countless patients, because orthopedic OPD consists of only rheumatoid patients or related patients, except trauma, congenital anomalies, and infection. Except these three, every other patient in our orthopedic OPD is a rheumatoid patient or an associate rheumatoid patient. If you consider these and treat these patients according to what I have been doing, office orthopedics will not give you any time to go and operate even. Thank you very much. Thank you. If you have got any questions, I'm ready to answer. Dr. Ashok, are you there?
Hello.
Hello.
Yes, sir, I'm there. My laptop got discharged, so again I reconnected. Sorry, sir. Sir, one question. A normal orthopedic surgeon like me, we always are at fear to start and DMARDs to the patient.
That is the fear which I want to alleviate from your mind.
Yes, sir.
That is the fear which was in my mind also when I was in your age. Over the period of 35 years, this prescription got modified into a form where there is no fear. Where there is no fear. This is in use in many junior colleagues and friends all over India. And their OPD footfall has increased many folds. Because why does the patient come to me? For pain.
Yes.
And if I can deliver a pain-free life pain-free mobility, who is going to subject his limb for a surgery? It is the pain which motivates the patient for a surgical intervention. Majburi mein karta hai. If there is no pain, they may be walking with a lurch, but there is no pain, they will not come to you for a surgery.
Definitely.
So what I have been embarking on, I have been emphasizing on that all the young colleagues, they should use DMARDs in their, but when you start DMARD, get the primary basic blood test. CBC, ESR, CRP, SGPT, creatinine, sugar. And within a month, you get a ultrasound also of the whole abdomen. Because most of these patients have a fatty liver. Many patients have kidney stones. And many patients have IBS. So that should be known in their mind that when I came to see the doctor, I already was suffering from this was the picture. That's it. So that they cannot, an illiterate orthopedic surgeon may blame you that your medicine has caused this. So what you need is these are the things which can be done in any city. A plain X-ray, which we already get done, X-ray of the pelvis, especially if a woman patient is there. See Dr. Mukherjee's sign there and find out on your own whether the patient needs Dr. Mukherjee's regime or not. Give me only 2 patients per week and give me the feedback.
Sir, actually, we have already started the famous Mukherjee regime for 4 patients of AV and hip. Since we met at IOA Con Goa,
yes,
that time I took that regime from you, and we started, and they are happy, sir. Pain has already gone.
Why it is good? Because the regime is safe in years of use. It is not only 3 or 4 months. The regime is safe in my patients who are taking this for years together. And they are still queuing up in my clinic for the next dose. Only thing that subsequent dose, according to the ESR and CRP level, I will have to reduce the dose to a level where there is only a top-up dose, so that the disease is under remission. Why does the avian reverse? Avian reverses because the thrombosis reverses.
Yes.
If I give my regime to a patient who has got dark colored black feet or leg in chronic arthritis or in chronic hypertensive patient, they start reversing and the skin becomes healthy and normal. The nail starts growing in the toe. The ingrowing toenails gets cured. It is because of the poor perfusion in the lower limb that the ingrowing toenail is happening. Because the nail is not growing, that nail is getting hard. You understand? You see the nail of an old man, how hard it is. It is because of the poor perfusion and atherosclerosis and lupus in the lower limb. Discolored skin. Once I start giving my treatment, within 6 months, within 1 year, I see that the skin has become normal. The nails have started growing. Pairing is easy. The ingrowing toenail is better. Because of the lower limb, because we are in an erect position on our both the feet, that the blood is getting static in the lower limb. And that causes dependent edema. The most common cause of edema in the leg is not heart attack or not cardiogenic or nephrogenic. It is because of arthritis.
Yes, sir.
Most common cause of pedal edema is arthritis. Later on with age, it becomes cardiac or due to CKD or chronic kidney disease like that. But to our side, we should always touch our patient's feet. If the temperature of the feet is low, less, then it is the circulation problem. And this regime will improve the circulation in the lower limb. So you try it yourself. It is not a question that this is my theory or my regime. You can say it is Ashok's regime. It is not Aroop Mukherjee's.
We have already started. So you had, in your experience, you had prescribed so many patients. Any adverse effects you had come
Not
across?
at all. Because see, this is when I am serving you. After I have taken this regime in about 6 lakh prescriptions. Then I am telling it to Ashok, then I am telling it to other people that why can't you try this?
Right.
There is no monetary transaction between me and telling others. I am not selling any implant. I am not selling any technique of surgery. It is simply because we, as a surgeon, our thinking is always doing something surgical. And avian is a medical problem. Now you run after the patient with a drill कि तुम उसमें वो करा लो.
खेत करा.
हाँ, फिर उसके अंदर हाँ उसके अंदर कोई स्टेम सेल डाल रहा है. It is our bent of mind. एक बच्चे को तुम हैमर दे दो, he will try to fix everything in the house with that hammer. तो वो सर्जन का वही हालत है. He has got a knife in his hand. He is trying to fix everything with his knife. नी खराब हो गया है तो चलो नी बदल दो. हिप खराब हो गया है तो चलो हिप बदल दो. So this is a wrong disease in a wrong faculty. Or we have to change our mindset that this is a medical problem. And multiple times I have shown my follow-up results of reversal of avian. Today also I showed my arthritic knee with 0 joint space, with some joint space, and the patient is happy 2 years down the line. Today also I showed a woman who has gone from 73 to 75 and has improved inner bone density in BMD DEXA. That is what the pharmaceutical companies are chasing me. Why can't you take a lecture in osteoporosis and promote teriparatide? The credit goes to the set of medication which suppresses the inflammation,
Yes.
which suppresses the CRP, which suppresses the ESR, which reduces the tension of the system. Because of this stress, the steroid secretion of an arthritic patient is many times higher than a normal patient. And a normal person को इतना stress होता ही नहीं है, because the stress is maximum stress is caused by the inflammatory cytokines in the body, and the liver responds primarily as a fatty changes because of this elevated CRP and ESR. The liver thinks that there is an impending danger to the body. It starts collecting fat as a energy source. And when this fat spills in the blood, then you get dyslipidemia. Why there is a high? All the arthritis patient, you take my words, most of the patient with the knee pain, you will find they have got a fatty liver. करा के देख लो. If you are doing an OPD, आप पेशेंट से कहो कि तुम अल्ट्रासाउंड कराओ. Gallstones may be a coincidental finding. But fatty liver will be a universal finding. Why? Because liver goes into a state of emergency by collecting and shows the urgency to collect the fat by even converting food into fat. So that is what the message is. So please, in case you find any problem, you can call me and talk to me. Let us discuss.
Yes, sir. I had called you a couple of times in the past. Yes, sir.
Let us discuss and sort out your problem.
Yes,
I'll be most happy. Thank you for a patient listening.
thank you, sir. Thank you, Arup. So this West Zone Indian Orthopedic Association CME. The topic is Office Orthopedics. We conclude it, and in between there was some power issues and some, like, my laptop got discharged, but then again I joined. So we will have this same session, that is part 4, on next Sunday, same time.
Okay.
So I thank all of you. I thank OrthoTV for allowing us and projecting this program. And thank you, Aroop sir. Thank you,
Welcome, welcome.
Bijlani, Dr. Bijlani, and see you next Sunday, same time. Thank you very much.
Bye bye.